today. And we very much appreciate all of our panelists who are here today. Over the past year and a half, the COVID-19 pandemic has changed so much about how we live our lives. To stay safe, we changed how we work, how we see friends, and how we connect with family. But nothing changed so fundamentally as our relationship with healthcare. Staying safe became a daily question. At times, hospitals and emergency rooms were full, leaving patients with nowhere to go. Doctors needed new ways to care for their patients that wouldn't further expose them to a virus that could threaten their health and well-being. To solve this problem, many doctors and patients turned to telehealth. At the start of the pandemic, from February to May of 2020, the U.S. Department of Veterans Affairs reported weekly appointments on their telehealth application surged from 10,000 to 120,000 a week. Nationwide, weekly telemedicine visits increased over 2,300%. The number of telemedicine appointments are now 23 times higher than they were before the pandemic. Nearly 1 in 3 healthcare visits now use telehealth services. But not only did usage go up, the landscape of American healthcare changed. According to data by the Department of Health and Human Services, before the pandemic, over half of all community health centers were not equipped to provide telemedicine services. Today, that number is under 5%. Physicians have found ways to incorporate telehealth, including audio-only options, into their practice, and patients have seen benefits from the convenience and accessibility that these services have offered. These services kept Americans safe when ICU beds ran low in Doña Ana County in New Mexico. Local public and private partners rapidly assembled a remote telehealth monitoring program. This allowed many patients to recover in their own homes while still under the supervision of trained medical staff. The program freed up beds and saved lives. I want to thank Ranking Member Thune for his partnership and willingness to engage in this discussion, and also to Chair Cantwell and Ranking Member Wicker for their leadership in making historic investments in telehealth over the last few years. We all see the urgency here. Congress appropriated $450 million to the COVID-19 telehealth program in the CARES Act and the Consolidated Appropriations Act to increase telehealth services. Thanks to Acting Chair Rosenworcel's leadership, the Federal Communication Commission continues to support essential connections for telehealth. The Commission helps fund secure, confidential, remote medical consultations, especially for those living in rural areas. That's why we're here today. Over the past year, New Mexico received over $1 million to help connect patients. This funding will help improve healthcare in the Presbyterian Medical Services in Santa Fe and Albuquerque, and First Choice Community Healthcare, South Valley Family Health Commons. These programs are essential, but our work is just beginning. Digital divide is standing in our way of connecting all Americans to this vital service. According to the FCC, 14.5 million Americans lack even a low-speed broadband connection. These communities are effectively cut off from many of the benefits of telehealth. Native American and Hispanic communities are less likely to have access to high-speed broadband and are less likely to take advantage of telehealth services. Rural areas continue to face higher costs for broadband infrastructure. We must connect every American to high-quality, affordable, resilient broadband. Without it, the current patterns of inequality will continue to grow. The Bipartisan Infrastructure Investment and Jobs Act includes $65 billion to increase broadband access and adoption. We urgently need to deliver this relief to communities across the country. Families must be able to talk to their doctor without worrying about hitting a data cap. Critical remote monitoring systems must remain online during network outages, bad weather, natural disasters. These are priorities that I've long advocated for, and I'll continue to lead the fight in many of these areas and work with my colleagues to solve these challenges. Finally, to ensure every American has access to telehealth, we must focus on solutions that work for underserved and unserved communities. Underserved by broadband, underserved without access to critical health care. The solution must include access to affordable broadband internet service, support for connected devices, and access to digital literacy programs. We have a distinguished panel of experts today to discuss the state of telehealth in the country, consider existing barriers, and explore solutions. I want to introduce them before I turn this over to our ranking member as well. Dr. Aurora, he saw a critical gap in specialized care in New Mexico almost 20 years ago. Since then, Project ECHO has reached over 1 million participants. Commissioner Carr has traveled across the nation, gathering stories and evidence of the need for rural telehealth access, and turned that into policy initiatives. Ms. Larson has made a career of her passion to provide better access to quality health care and specialty services for residents of rural communities. And Dr. Ranzo has seen firsthand how telehealth can enhance the patient-physician relationship, taking up that charge as president of the American Academy of Family Physicians, and I look forward to their discussion today. I now want to recognize Ranking Member Thune for opening remarks.
Good morning, and thank you, Chairman Lujan, for holding this hearing. As a resident of a rural state, I've long been a proponent of telehealth for the access it gives to rural communities. If you live in a major city, you usually don't have to think too much about where you'll find a doctor if you need one, but that's not always the case for Americans in rural areas. In the smallest towns in America, access to specialty care can be a challenge. The only providers may be primary care providers, nurses, pharmacists. These providers are essential to rural families, and there are times when specialty care is needed. And when there isn't a specialist close by, telehealth can help get patients to the medical care they need from a remote location through the use of technology. Telehealth services are also critical in nursing home facilities. In my state, we have strong programs designed to bring on-demand support into facilities to help avoid unnecessary emergency department transfers. By reducing unnecessary senior hospitalizations, my Reducing Unnecessary Senior Hospitalizations Act, or the RUSH Act, would help facilitate more arrangements like we have in South Dakota, allowing medical groups to collaborate with nursing homes to provide telehealth services through a Medicare alternative payment model. I'm also pleased to support the bipartisan Connect for Health Act, which aims to expand telehealth services through Medicare and is supported by more than half of the United States Senate. The Bipartisan CARES Act played an important role in further expanding access to telehealth throughout the COVID-19 pandemic, and I look forward to continuing the conversation with my colleagues at the Senate Finance Committee on the path forward for Medicare reimbursement post-pandemic. And in my role on this committee, I will continue to advocate for the expansion of broadband services, which has allowed more patients in rural areas to take advantage of telehealth services. It is critical that any additional broadband funding goes to truly unserved areas so we can expand the reach of next-generation services like telehealth. The Federal Communications Commission plays an important role to help expand telehealth services through a number of programs. Congress, acting in a bipartisan manner, provided a significant amount of funding for the FCC's COVID-19 telehealth program through the CARES Act and the year-end coronavirus relief package. Several healthcare providers in all 50 states have been able to participate in this important program. In my home state, there are a number of excellent healthcare providers expanding access to telehealth services by participating in this program. The Community Healthcare Association of the Dakotas received funding for equipment necessary to expand remote patient monitoring and other telehealth services in community health centers. Sanford Health was able to utilize funding to secure wireless access points, which is necessary to conduct confidential telehealth appointments. And Avera Health and its affiliated Aval eCare, represented on this panel today, received funding for a number of services, including remote monitoring equipment and software to provide care for chronically ill patients in their homes. In addition to the FCC's COVID-19 telehealth program, the FCC's Universal Service Fund provides support for the Rural Health Care Program and for the Connected Care Pilot Program, which was spearheaded by Commissioner Carr. I appreciate Commissioner Carr taking the time to speak with us today about these programs. It's my hope that we will see you again soon before this committee, as there are many other important issues at the FCC of interest to members here. And lastly, I'd like to extend my thanks to Ms. Deanna Larson, who's president of Aval eCare, for joining us today. As president of Aval eCare, Ms. Larson has helped advance telehealth services across many areas in the Midwest. Thank you to all of the witnesses for being here today, and I look forward to hearing from you. Thank you, Mr. Chairman.
Now recognize Ranking Member Wicker for opening remarks.
Thank you very much, Chairman Lujan and Senator Thune, for convening this important hearing on telehealth. We've got someone here from South Dakota. We have someone here from New Mexico, and us folks in Mississippi kind of think that Brendan Carr is an honorary Mississippian. So please see him here, and of course, he's the leading voice for telehealth on the FCC. Telehealth is becoming an indispensable part of our healthcare system. The COVID-19 pandemic only accelerated the expansion of telehealth as more aspects of our lives moved online. Today, millions of Americans, particularly in rural and underserved communities, rely on telehealth for real-time and continuous access to medical care. Telehealth is highly cost-effective and convenient for both doctors and patients. Doctors are able to monitor their patients' conditions from afar, collaborate quickly with other health care professionals, and provide faster diagnoses and treatment. Telehealth also helps patients to manage their own health. Patients can track their symptoms, send vital information to doctors, set up medication reminders, and much more. These services are especially helpful to rural Americans, veterans, and other underserved populations who routinely face doctor shortages and hospital closures. I've long supported the expansion of telehealth. In 2018, Commissioner Carr and I visited the University of Mississippi Medical Center to unveil the FCC's new Connected Care Pilot Program. UMMC's Center for Telehealth is a national leader in telehealth, providing high-quality care to thousands of Mississippians and Americans across the country. The FCC's Connected Care Pilot Program is currently studying how investments from the Universal Service Fund can support patient and provider use of connected care services, and how that support can improve health outcomes and reduce costs. I'm proud to have led efforts to include $450 million in the FCC's COVID-19 telehealth program in the CARES Act and the Consolidated Appropriations Act. These funds help reimburse providers for the connectivity and devices they need to keep telehealth available during the pandemic. Ultimately, we will not realize the full benefits of telehealth without reliable broadband access. Senator Lujan, in his statement, correctly said we must conquer the digital divide in order to have effective telehealth, and he's correct there. More than 14 million Americans lack access to a broadband connection, and a vast majority of those Americans, 11 million, live in rural areas. Our nation's rural communities should have access to the range of benefits that come from having a broadband connection, including telehealth. I hope the broadband investments we are making, both at the FCC and through the bipartisan infrastructure bill, will help achieve that goal. Today's hearing is an opportunity to discuss our progress in making telehealth more accessible, and I appreciate the leadership of this subcommittee in forwarding this issue. Thank you, Mr. Chair.
Thank you, Ranking Member Wicker. And next, we'll recognize our witnesses for their testimony. We're first going to hear from Dr. Sterling Ranson, the president of the American Academy of Family Physicians and a practicing physician coming to us from Deltaville, Virginia. Dr. Ranson?
Thank you. Chairman Lujan, Ranking Member Thune, and members of the committee. I'm Dr. Sterling Ranson, president of the American Academy of Family Physicians, and I'm honored to be here today representing the 133,500 physician and student members of the AAFP. In addition to my leadership role at the AAFP, I'm the physician practice director at Riverside Fishing Bay Family Practice in Deltaville, Virginia, and an assistant clinical professor of family medicine and population health at Virginia Commonwealth University. I've practiced in a rural community for more than 20 years with my wife, who's a pediatrician, and I've seen firsthand how telehealth can be used as a tool to enhance the patient-physician relationship, increase access to care, improve health outcomes by enabling timely care interventions, and decrease costs when utilized as part of a patient's medical home. Full success of telehealth cannot be achieved without significantly improving our nation's broadband infrastructure. The ongoing pandemic has highlighted the importance of broadband for access to many primary care services, especially in the areas of mental and behavioral health care. Broadband access must be recognized as a social determinant of health. The COVID-19 pandemic has underscored the strong link between digital equity and health equity. In order to realize the potential of telehealth and address health disparities, Congress must invest in efforts to ensure universal access to affordable broadband services for all individuals and their healthcare providers. The AAFP supports the FCC's Rural Healthcare Program, which has helped many rural clinicians obtain high-speed broadband connections. This has allowed practices like mine to implement telehealth services on site, which can in turn provide patients access to tertiary care by connecting them and me to remote specialists. However, to provide virtual primary care to patients at home, both the clinician and the patient need access to broadband. Many of my patients, particularly those enrolled in Medicaid, are unable to afford high-speed internet at home, which affects their ability to use telehealth services and limits my engagement with them outside the office. Beyond virtual visits, the lack of broadband access is also limiting the potential of other digital health tools, such as patient portals and remote patient monitoring. It's not enough simply to expand access to broadband. Congress must ensure that patients in need of access end-user devices, such as tablets or computers, we need them to connect to digital health tools, and we should invest in training and assistance so patients can confidently use those tools to ensure that they are not further marginalized. For many small physician practices, the cost of telehealth technology can be prohibitive. In addition to hardware costs, many telemedicine vendors charge setup fees up to $3,000 and recurring subscription and transaction fees. Congress should ensure that small practices are adequately supported, either by making them eligible for funding through existing FCC telehealth programs or by creating a new program. Supporting telehealth adoption within these offices will improve equitable and timely access to health care and promote competition by enabling smaller practices to remain independent. As this committee is acutely aware, our nation has a long way to go before all Americans have high-speed broadband and the tools and knowledge to leverage it for virtual video healthcare visits. Further, there may be times that an old-fashioned phone call is the best way for a clinician to access and treat a patient. Therefore, it's critical to preserve access to audio-only telehealth services provided by a patient's usual source of care. Coverage and payment policies should support patients' and clinicians' ability to choose the most appropriate modality of care. As a family physician, I'm a highly trained professional, and I adhere to the standards of care. I also truly know my patients and have formed trusted relationships with them over the years. No two patients or cases are alike, and I should be able to choose how to best care for them based on my clinical judgment, not based on arbitrary insurance rules. Telehealth benefit expansions must increase access to one's own physician and promote high-quality, comprehensive, continuous care. Expanding telehealth services in isolation without regard for previously existing patient-physician relationships, knowledge of medical history, or the eventual need for a follow-up hands-on physical exam can undermine the basic principles of the medical home, increase fragmentation of care, and lead to the patient receiving suboptimal treatment. Telehealth can't fully replace in-person care. Federal policy should support physician practices like mine in adopting and sustaining telehealth availability so that we can serve our patients both virtually and in the pandemic. The COVID-19 pandemic has illustrated that telehealth can be an essential part of healthcare, but more needs to be done to ensure that every person in every community of our country has access to high-quality virtual care as part of their medical home. I appreciate the opportunity to discuss our recommendations with the committee. Thank you.
Thank you, Dr. Ranto. Next, we're going to hear from Commissioner Brendan Carr of the Federal Communication Commission. Commissioner, floor is yours.
Thank you. Chairman Lujan, Ranking Member Thune, Ranking Member Wicker, distinguished members of the committee, thank you for the invitation to testify. I'd like to begin by commending the subcommittee for convening this important hearing on telehealth and for the leadership that members here have shown in supporting these vital offerings and extending internet connectivity to more Americans. Expanding access to telehealth has been a top priority for me, and it's one that has long benefited from bipartisan support at the agency and here in Congress. In fact, I've had the chance to see firsthand the benefits that telehealth brings to communities across the country. In New Mexico, on a visit to the Mescalero Apache Reservation, I met with the team at the Mescalero Indian Hospital. Thanks to a high-speed connection, community members can now have one-on-one video sessions with world-class mental and behavioral health specialists located all the way back in Albuquerque. Without telehealth, this type of care would be out of reach for many people in that community. I've seen similar benefits in remote parts of South Dakota. In Pine Ridge, I toured a smart emergency room that connects hundreds of miles away back to Sioux Falls. A team of emergency room specialists there can walk the generalists at Pine Ridge through complicated emergency procedures in cases where there's no time to transfer a patient to a more specialized facility. This important form of telehealth, connecting one facility to another, is vital. With rural hospitals closing, a shortage of specialists, and the challenges of traveling long distances for care, we must continue to support this mode of telehealth. At the same time, there's a complementary trend emerging. Whether you call it remote patient monitoring or connected care, patients are no longer limited to receiving care in person at a brick-and-mortar facility. I first learned about this new trend on a visit to the Mississippi Delta with Senator Wicker a few years back. And that's where I heard about an innovative program that sent diabetes patients home with a blood glucose monitor and a connected tablet. The constant monitoring and feedback improved outcomes for those patients, and I thought we should build on that model back at the FCC. So I worked with my colleagues to create a $100 million connected care pilot program. We stood that up last year and so far awarded a total of $58 million. Of course, COVID-19 only underscored the importance of telehealth. As the pandemic emerged, Congress passed the CARES Act, which provided the FCC with $200 million in additional telehealth funding. We used that to stand up a new COVID-19 program that built off the connected care model. We awarded all of that funding by July 2020, and Congress then provided the agency with an additional $250 million. So far, the FCC has committed $80 million of that round two funding. All told, I've had the chance to visit with 44 healthcare providers in 22 states, including many of the FCC awardees. And those visits have brought home the unprecedented spike in telehealth over the last 2 years. In Parsons, Kansas, a provider just told me their visits jumped from close to zero before the pandemic to about 1,200 a month. At the University of Michigan, doctors there saw a 75-fold increase in telehealth visits. And just yesterday in Florida, a pediatrics department told me that their telehealth visits grew from 25 a day to 1,800 a day. The data also confirmed the significant benefits from telehealth. Yet barriers remain, from legal and regulatory to connectivity challenges. For instance, there have long been a range of licensing and reimbursement issues. HHS eliminated some of those hurdles last year through waivers, but those are set to expire when the pandemic ends, and we simply can't afford a return to the status quo. And that's why I've supported many of the bills that members of this subcommittee introduced, including the bipartisan Connect for Health Act, that would extend those waivers. There's more the FCC should do too. For one, connectivity is key to telehealth, so we need to continue our work of closing the digital divide. That means more spectrum and further streamlining of infrastructure rules. For another, we need to ensure that our telehealth programs deliver on their important goals. This means quickly finalizing the award of the remaining portions of telehealth funds. We're taking another good step in that direction later this month at our open meeting, so I want to thank Acting Chair Rosenworcel for bringing a vote forward on that issue. This also means working with stakeholders on a long-term solution to funding these types of initiatives. And this means ensuring that our rural health care program provides the sufficient and predictable level of support necessary to meet the needs of rural providers. It's fallen short before, and I've been working with my FCC colleagues on fixing those shortcomings. I look forward to making more progress on that. In closing, I want to thank you again for the opportunity to testify today. I look forward to taking your questions.
Thank you very much, Commissioner Carr. Next, we're going to hear from Ms. Deanna Larson, the Chief Executive Officer of Able eCare in Sioux Falls, South Dakota.
Good morning, Chairman Lujan and Ranking Member Thune and Ranking Member Wicker. Good morning. Chairman Lujan and Ranking Member Thune and Ranking Member Wicker. Very happy to be here this morning. Honored to represent the many stakeholders and the providers of telemedicine who are using this modality to deliver healthcare across the nation. Being based in Sioux Falls, South Dakota for the last decade and a half of telemedicine has given us a lot of experience in rural care. We now have locations of sub-locations in Michigan and in Texas. I have the honor also of serving on the board of the ATA, so we hear a lot from many members across the nation about issues and great outcomes as well. By way of background, we began providing telemedicine services in 1993, really providing specialty care, clinic to clinic, for patients and individuals who couldn't make it into out of the rural settings into tertiary. We now provide acute care for ICU, hospital medicine, emergency medicine, behavioral health services, specialty clinics, school health, as well as in skilled nursing facilities. So essentially, we are a virtual healthcare center augmenting care in rural locations. So how did we get to use the FCC funds? We were very excited about the opportunity. During the pandemic, there was pandemonium in healthcare. It's usually a fairly it's usually a very controlled environment, and all of a sudden, everything was not controlled. So overnight, we developed training and moved out telemedicine, has been earlier described, both to clinicians and residents. Brick and mortar closed, people were needing access to care. So we're needing to extend those services using now providing the funds from the COVID Telehealth Relief Program. We were able to extend those services in emergency settings, skilled nursing facilities, and in home monitoring. 84 communities in 7 states. We were very grateful to receive those funds. It all went directly to expansion of that equipment. On behalf of those customers, we're really grateful for all of that work, but we know that there's still a lot of opportunity. There are still underserved communities as it relates to broadband. We have experience where we haven't been able to get into communities for up to 2 years of time. Up to 2 years of time in Montana, where individuals are seeking care, telemedicine services, and there's no access, there's no way for us to get to them. While we're very grateful, we know there's a lot more to do. So it's really important, broadband for us. It is the essential piece. As we really made a shift during the situation and the kind of pandemonium of telemedicine, we made a shift with providers. The paradigm moved. Clinicians all of a sudden understood the power of telemedicine. Patients were willing to accept it. Now we need that critical vehicle of broadband everywhere to make that happen. An example of that is the use of broadband too. I want to mention, it's been brought up before. Is it telephone? Is it video? Is it store and forward? That's like asking a physician, you can only use a flat plate X-ray or CT scan or MRI. Should we be making that decision? Or should we leave that in the hands of physicians or clinicians who can make that decision, which use cases most treats their patients in the best way? We also are involved in the federal initiative, the National Emergency Telemedicine Critical Care Network, that's been sponsored federally. It's called NETSN. We're working with HHS, ASPR, and the Department of Defense to provide critical care expertise to hospitals, municipalities struggling still with the COVID-19 surges. Over the last year, we've been deployed over a dozen times to care for thousands of patients in the communities, ICUs, community hospital units, and also in patients' homes. We know we've been part of saving lives in those situations. We've supported health systems, alleviating bed shortages, and really supporting those vulnerable clinician workforce that now is out there. There's a very big scarcity in the workforce situation. I know important strides have been made to improve access, and we're very grateful in the broadband situation. I would urge the committee to continue to support new and innovation projects and initiatives that might alleviate these physical challenges we see, like in Montana. Let's keep an eye on Starlink and the satellite opportunities that might be coming around for us to have very affordable and continuous access. The Telehealth Flexibility Program, I urge every member on this committee and the administration to continue to extend the telehealth regulatory flexibilities created during COVID-19 pandemic. Or better yet, let's just make them permanent. Without this support, patients can lose access. We'll go back to the Great Divide, if you will, or as ATA calls it, the telehealth cliff. We will create, again, underserved communities that will no longer have access. The ability to provide these modality-neutral telemedicine, such as, again, the phone-only or asynchronous care, remote patient monitoring, really has proven to be essentially valuable. We also are very grateful for the FCC funding USAC program. We use it very well in many of these remote and rural programs. They're very grateful to receive those funds. It's been my experience over the course of my career to find telemedicine makes a great difference. It improves the overall quality of care that are reaching patients. It serves the community well. We often can keep patients in their small rural community, keeping the money in that community. We're able to support, retain physicians, clinicians in that community. All of that immediate care where it's needed can de-escalate the illness and reduce the cost of that care overall. Again, I'm very happy to be here and represent this and look forward to your questions.
Thank you so very much, Ms. Larson, and thank you for your challenge and our call to action as well. Next, we're going to hear from Dr. Sanjeev Arora, founder of Project ECHO and distinguished professor at the University of New Mexico Health Sciences Center in Albuquerque, New Mexico. Dr. Arora.
Chairman Lujan, Ranking Member Thune, and members of the committee. My name is Sanjeev Arora, and I'm the director and founder of the Project ECHO at the University of New Mexico. Thank you for inviting me to testify. As we have seen in the pandemic, we've exposed what we all knew instinctively. We need to fundamentally reorient our healthcare system to enable patients to get the care they need, when they need it, where they live. Last year, I testified before the Health Committee and shared a patient story from almost 20 years ago. A 43-year-old widow and mother had been diagnosed with hepatitis C 8 years earlier. Yet, she was just now seeking treatment for the first time. When I asked her why she had waited so long, she said her doctor told her that the treatment would require her to make a dozen trips to Albuquerque over a year, and she couldn't afford to take the time off work. Now the pain was too much for her to bear, but it was too late to save her. She died 5 months later from advanced liver cancer. We had the medicines and the expertise to treat her, but she didn't have the resources to get to us. And no doctor in her community had the knowledge to treat her disease. That's why I started Project ECHO, to get the right information to the right place at the right time to save and improve lives. Now we must enable telehealth of all kinds. Improving broadband will support all three domains of telehealth: remote monitoring, telemedicine, and telementoring. All three can advance health equity in rural and underserved communities. Remote monitoring gives us a unique window into the life of a patient. Picture an elderly woman wearing a wireless remote device that can alert us if her gait is unsteady and allows us to intervene earlier and prevent a fall and hip fracture. Telemedicine allows us to bridge a geographic divide and connect a specialist with a patient who would otherwise be forced to travel a long distance or go without care completely. Both remote monitoring and telemedicine are critical and needed and will be significantly enhanced by ensuring broadband connectivity to every household in America. But an additional serious constraint remains. The lack of specialists is not just in rural areas. Most urban areas also have an insufficient number of experts. There are simply not enough experts anywhere to serve all that need their help, and patients everywhere have to wait weeks and months to see a specialist. And that's where telementoring to build workforce capacity comes in. The All Teach, All Learn ECHO model works like this. Teams of experts at regional medical centers called hubs use one-to-many video conferencing to engage with local healthcare providers, the spokes, in ongoing weekly sessions with knowledge sharing and case-based learning to ensure that clinicians already on the ground in communities have the latest best practices, mentoring, and support they need to treat patients. Hub and spokes learn from each other. Everyone's knowledge is constantly improving. Based on the tremendous need, ECHO has grown and is now embedded at more than 250 organizations in all 50 states across the US. Many of these at major academic health centers like the University of Washington, University of Hawaii, MD Anderson, the University of Mississippi, and many, many more. And we know the model works. A study published in the New England Journal of Medicine on our hepatitis C work in New Mexico showed that patients got the same quality of care they would get if they went to a specialist. There are now more than 400 papers published to demonstrate the effectiveness of the model. We had long believed that the ECHO model could be put to work in a pandemic, and in 2020 it was put to the test. Since the onset of COVID-19, we have deployed our entire national and global network in response to the pandemic. Here are two quick examples. We worked with the Agency for Healthcare Research and Quality and the Institute for Healthcare Improvement to launch the nation's most comprehensive and successful effort to reduce the spread of COVID-19 in nursing homes. More than 9,000 nursing homes and more than 30,000 healthcare workers participated. We partnered with the Assistant Secretary for Preparedness and Response at Health and Human Services to run a national program for frontline providers focused on COVID-19. Every week, some 400 to 1,700 clinicians log on to this virtual community. More than 50,000 have participated. How can these lessons help us reshape our healthcare system to move life-saving information more quickly and efficiently? First, expanding access to high-quality, high-speed broadband connectivity is critical. It's a prerequisite for the success of any telehealth model in rural communities and urban underserved areas. Second, the FCC should explore any additional opportunities under its purview to support telehealth to improve care in rural and underserved communities. Finally, although mostly outside the purview of this committee, I hope Congress will commit to exploring longer-term changes to healthcare financing for approaches like telementoring that can support our healthcare workforce. I am committed to working with you to help realize the promise of telehealth in our country. Thank you for this opportunity, and I look forward to your questions.
Thank you, Dr. Arora. We'll now move to questions of our distinguished panel. I'll recognize myself for 5 minutes. At this moment, the United States Congress stands at a critical juncture. We're on the cusp of a historic bipartisan infrastructure package that invests $65 billion in broadband infrastructure and broadband affordability. This investment has the opportunity to improve connectivity and access to education, jobs, and critically, life-saving treatments. To start us off here, I have a simple yes or no question for each of the witnesses. Does access to high-quality broadband contribute to better health outcomes? Dr. Ranson?
Yes, sir, absolutely.
Ms. Larson?
Resounding yes.
Commissioner Carr?
Yes.
Dr. Arora?
Yes.
Thank you, and I think we all agree here. We must connect every American and ensure those networks are built to live up to the critical role they will play in our health and well-being. Dr. Arora, you're the director of a nationwide leader in telementoring project, but you are also still a practicing physician who has served the people of New Mexico for nearly 30 years. I'm deeply grateful for your tireless work that you've done for our home state in New Mexico. You've touched thousands of lives in Albuquerque and across our state and across America, and scaled that knowledge to provide expert care across the world. Thank you. A state like New Mexico faces many unique challenges in accessing healthcare. Many of my constituents live hours from the nearest community health center or hospital. For many, telehealth is the only way they can get care without having to take a day off of work or find someone to care for their kids. Dr. Arora, how can we ensure future investments in telehealth meet the needs of states like New Mexico, South Dakota, and Mississippi, and Hawaii? I'm gonna get in trouble over here in Kansas. So I'm gonna get in trouble as I look around. Dr. Arora?
But thank you, Chairman Lujan, for the question. The problem you have identified is present in every state in the United States. Many of our patients and healthcare providers in the most rural areas don't have access to adequate, high-quality broadband. So, of course, that would be enabling every different aspect of healthcare and produce equity in our healthcare system if we were able to fulfill the vision that you articulated of getting good broadband to every household and every healthcare provider in New Mexico. The biggest problem, Senator Lujan, that I see in the United States today is that in every state, there are such a long wait to see a specialist. Take the example of a dermatology consult in New Mexico. 30% of our land area has no dermatologists. There are only 33 dermatologists in the state of New Mexico, when we need more than 120. Even in Albuquerque and Santa Fe, the wait to see a dermatologist can be 6 to 8 months. It is not possible for this person to do a lot of telemedicine because he or she is so busy seeing patients all day long in Albuquerque and Santa Fe. And so telemedicine will overcome a geographic divide, but it does not overcome the biggest problem of a capacity constraint in our healthcare system. We need task shifting so we can enable physician assistants, nurse practitioners, primary care doctors, family doctors to provide fundamental dermatologic care in their local communities in a state where we have one of the highest skin cancer rates. Our patients cannot access dermatology care. And so I think the combination of all three types of telehealth that we talked about, remote monitoring, telemedicine, and telementoring with projects like ECHO, can be a solution, not just for New Mexico, not just for every rural state, but for the entire United States.
Thank you so
for your
much,
question.
Dr. Arora. Commissioner Carr, the Connected Care Pilot Program identified a critical need within the telehealth system. The Connected Care Program is designed to serve a critical need by targeting telehealth funding to communities that most need support. What's the future of Connected Care with the program, and do you recommend we move it beyond a pilot into a permanent program?
Thank you. Thank you. I always do that. Thank you, Chairman, for the question. The Connected Care pilot is set to run for 3 years, and part of the original idea was to get more data on how beneficial telehealth is. Well, the reality is with COVID, we stood up before it the emergency COVID-19 program, so we have even more data now. So long-term, yes, we need to make sure that this type of service is available. There's questions about how to fund that, but absolutely, we need to make sure we maintain support for these types of telehealth services.
I look forward to hearing more about that during the hearing today and in the future. Appreciate that. I'll now recognize Mr. Thune for 5 minutes.
Thank you, Mr. Chairman. Ms. Larson, how did the FCC's COVID-19 telehealth program help expand the reach of Avell eCare, and I used to know it as Avera eCare, but Avell eCare telehealth services, and is there anything that we should know as policymakers about the program? What worked well and what didn't?
We used the funds to create another situation of telehealth in more emergency settings, more skilled nursing facilities, and specifically in that home setting. So the funding really worked very well for us. Some of the things that worked very well and were difficult at the same time, it was very quick notice. You know, it seemed like we had to be first in line, and so we applied within 24 hours, which is no small feat when you're trying to collect all of those tools. But nonetheless, we were very happy to apply. I think that worked very well. We were able to get equipment out, and we were actually able to get equipment out quickly. The reimbursement for that equipment took nearly 12 months. So due to the paperwork and processes that are in place, and again, it wasn't, you know, it could have been part of our issue too, but that is part of how do we streamline that so that we aren't using extra time to try to make those things work very efficiently. I do believe it was a great program, and it funded what we needed to have to extend our programs. We did not apply for the second one, not sure. Remember, there was a lot of unknowns during that time. Not sure when funding the reimbursement would be coming, and then again, the notice to get ready so quickly. But we deeply appreciated it, and we're able to impact hundreds and hundreds of lives through the funding we received.
Well, it seems like we ought to be able to improve on a 12-month reimbursement rate, even for organizations as inefficient as the federal government. Commissioner Carr, could you talk about some of the lessons learned from the COVID-19 telehealth program and what other initiatives are underway at the FCC to support telehealth services?
Well, I think one of the most interesting lessons learned is how much uptake there was for these services. We talked about the 75-fold increase depending on the facility. People found this very easy to use, preferable to use, health outcomes improved. So we do need to move down this path, and I think finishing the award of funds from our existing programs would help, and looking at how do we sustain this from a payment perspective long-term are some important steps we need to take.
Tell me about, we know telehealth services have dramatically expanded with the improvement of broadband services in rural America. You all have testified to that. What steps has the FCC taken to expand reliable and affordable broadband services to unserved areas, and what needs to be done to make sure all the broadband funding provided by Congress goes to truly unserved areas?
Well, there's a lot of steps we took over the last couple of years to streamline infrastructure rules. A lot of it was looking at some of the legislation that you all have been working on. We pushed a lot of spectrum out, building off of the Mobile Now bill that you all introduced. And going forward, we need more of the same. One, we need to continue to streamline infrastructure rules. Two, we need to continue to get spectrum out there. I've put a spectrum calendar out that would make sure we do that. And importantly, we have a lot of funding right now in the pipeline that we need to get out the door, whether it's RDOF Phase 1, which we only have a couple percentage points of the total award moved out the door yet. So we have funding in the pipeline that we need to get going, because as I did a visit with Senator Wicker, there's broadband builders that won funding that are ready to go. They're just waiting on those dollars to get to them.
And what does it take to get that going faster?
Well, I'm not sure. We're behind schedule in terms of the CAF2, which is an analogous program,
Right.
in terms of the percentage of funds that we got out the door. So we got to keep moving on that. Obviously, long-term, the maps are going to be key. We got to complete those maps. That's what's going to let us go to RDOF Phase 2, 5G fund, and get more support for broadband builders in rural communities.
Okay. It always comes back to the maps, doesn't it? Been working on maps for a long time. Ms. Larson, how have you seen expanded broadband services improve patients' and healthcare providers' experience in areas that have lacked sufficient healthcare services, particularly specialty care services? Can you talk about that?
You know, I think a great example of this is the care and services, especially through the opportunity with the COVID relief pieces. We were able to provide in two of the IHS areas, both the Billings area and the Great Plains area. Previously, you know, there hadn't been enough access for us to provide care, and having broadband available. The last one was in the Billings area. We were actually able to reach another tribe location and a service unit area. We increased, through the relief, we were able to increase the behavioral health services response. So able to provide care in the home through behavioral health versus having to go to a clinic. The no-show rate of those individuals reduced by up to 40%. So now we're reaching 40% more of the individuals coming on a telehealth visit, receiving behavioral health services. So, you know, the availability of that in the home setting, and because broadband was now brought out there, they could actually use their phones in their home situation to have behavioral health services. Huge extension, and the clinicians in the behavioral health arena specifically are very comfortable on video or on phone. I mean, we have many physicians in many specialty areas that are comfortable at this point, but it's especially interesting that individuals with behavioral health needs are more comfortable in a location, not always in a clinic setting, maybe in their home setting. Also, the providers in behavioral health are telling us they can learn more. The patients are more comfortable in their home setting. They also can see the environments behind them or around them to help them understand maybe what's happening with the individual, which is not something you can get if the individual comes in and is not able to really communicate easily in the clinic setting. So taking broadband out across the reservation areas has enabled physicians. I've mentioned behavioral health. There's also dermatology. There's endocrinology. We know the situation with diabetes in that population, able to manage and control that with individuals not always in the clinic setting, but making broadband available in that setting also gives our specialists the ability to be in the clinic and work remotely with those clinic physicians.
Thank you. Thank you, Mr. Chairman.
Thank you so much, Mr. Thune. Next, we'll recognize Senator Schatz for questions.
Thank you, Mr. Chairman, and thank you to the chair of the whole committee for deferring to me. Dr. Ranson and Ms. Larson, as you know, we're facing a telehealth cliff because the authority that has expanded Medicare's coverage of telehealth expires when the COVID-19 public health emergency ends, and unless Congress acts, we will go back to the Stone Ages with very limited access to telehealth. And I think people are sort of underestimating the shock that will occur across communities if we don't deal with this cliff. I've introduced a bill, the Connect for Health Act, that has the support of more than 60 senators on a bipartisan basis that would make this expanded coverage permanent. So Dr. Ranson first, and then Ms. Larson. Could you speak to the disruption in healthcare delivery if we don't fix this?
Thank you, Senator. There will be an incredible disruption in my ability to take care of my patients when we reach this cliff. For family physicians nationwide, prior to the pandemic, about 15% of our members provided telehealth services. And because we were concerned about the safety of our patients at the beginning of the pandemic, we quickly transitioned to approximately 6 weeks later, over 90% of our members provided telehealth services to our patients. It's critically important that we are allowed to have funding to help us take care of these patients in a virtual environment. The concerns that I have are multiple should that funding evaporate. Number one, virtual care has allowed me to expand my house call services. I've done physical house calls for years. However, because of patient safety, because of distance, and because I'm in a rural area, allowing me to access the patients that I've known for years in their home has allowed me to keep many of my patients out of the hospital. So this is a big cost savings for our entire healthcare system. When we can go, we can monitor our patients closely. We can keep them from going downhill, and we can keep them out of the hospital. So continued funding is incredibly important. I'd also like to put in a little push for continued funding of audio-only telehealth services. I see many geriatric patients, and rarely do I see a patient over 75 who's not there with someone who is younger. Typically, they have a family member who is there helping them bridge that digital divide, helping them use the technology that's there. And more frequently, my patients 80 and over just don't have that technology. A flip phone is considered very advanced for them. So they use audio-only telemedicine services, and I use that to help monitor them and help keep them healthy. I think keeping that availability of audio-only telemedicine services and funding thereof is incredibly important to help me take good care of my patients. Thank you.
Ms. Larson.
So I would echo a few of those comments. It's very important to us that geography is not limiting where we can really see individual patients. Workforce is an issue. You know, we have to remember that physicians or clinicians having to travel to locations to see, in our rural states, they may travel 60 miles one day or more just to get to a clinic to see patients. Can I have that in a skilled nursing facility? You know, really making sure that location is not a barrier, and in the home, ensuring that that same clinician doesn't have to take the time, unnecessary time to travel where they can actually see the patient in their home. Not to mention, remember, many of these individuals don't have the ride that was just earlier mentioned. They'll forego it. They won't ask their daughter or their son to take the day off to take them to the nearest setting when we can be right in their home with them. That's a huge and important, it really, absolutely, people will fall through the cracks if we're not able to continue to see them in their home.
Right, and for the technicians, you know, who develop these statutes and the people who work at CMS, and people on the finance committee, we talk about that as the home as an originating site. But the practical implication is really significant. It's a matter of life and death. It's a matter of whether or not you can get care, because if you still have to go to your car, get into some either public transportation or get a ride and schlep someplace, it defeats the purpose, at least partially, of telehealth in the first place.
It absolutely does. And, you know, the spiraling, remember that since COVID, too, many families are trying to care for their senior family members in their home, which means they're not in skilled nursing facilities today. So even in skilled nursing facilities, but now in the home, we see escalation of illness if there's delay. So what does that cause? What does that cost us? So if we can't immediately see an individual when they start to feel ill or have a situation going on, if we're waiting, now that individual is going to be seen probably in an emergency department with an escalated illness and maybe even hospitalized, we can prevent much of that.
Thank you. One final question I'll submit for the record, but I'm very interested in the behavioral health piece, especially for adults in the community with severe and persistent mental illness. I used to run a nonprofit that provided services to people with severe and persistent mental illness, and a lot of our case management was just finding the client, physically locating the client. And technology has advanced to the point where we can make sure that those, and oftentimes it's billable hours, It's a fee-for-service arrangement. But a lot of those billable hours were chasing someone and trying to locate them. And this is a problem that telehealth can solve and make sure that the system is efficient in delivering care, not just activities related to trying to deliver care. So thank you. I'll submit that for the record. Thank you.
Thank you, Senator Schatz. Next, Ranking Member Wicker.
Thank you very much, Commissioner Carr. When do you think the FCC will have the new maps ready?
Well, it's a good question. It's a bit of a black box, but I don't think it should be. Back in March, I said we should get them done by this fall, at least a targeted set of maps that lets us go forward with RDOF 2 and 5G fund. I'd heard that they may get done this summer, but there are no maps at this point.
Is there a sense of urgency in the FCC?
I'm sure there is, and so I don't know what the difficulty is. Obviously, getting these maps together is a very complicated process, but we obviously do need to get them done.
Okay, so is this a staff problem, or do you need to get back to us on that?
I'm happy to. You know, we obviously got almost $100 million from Congress at the end of last year to get this done, and we need to because it is holding up the distribution of funds that could further bridge the digital divide.
Okay, well, pass along that I'd like to see a sense of urgency from everybody within the FCC, and I hope I get some amens up and down the dais on that. Amen. Commissioner, USF is funded by contributions from telecommunications providers who pass the cost to consumers. The contribution rate, which is a tax, is climbed. I have a bill called the Fair Contributions Act, which directs the FCC, which would direct the FCC to study whether big tech should also contribute to the USF fund, because these companies overwhelmingly benefit from broadband. So how can, do you think that would be a good way to ensure that the Universal Service Fund is on a stable and sustainable path?
Well, thank you, Senator. I think that's a great bill, and it tackles an important issue. There's a 30% charge that we add to the telephone portion of consumers' bills. A study that came out a couple weeks ago said that that could spike to 75% if we don't do something different. And your legislation would have us look at what I think is a much more fair way of doing that, which is looking to the large tech companies that benefit to the tune of trillions of dollars from these investments in the network. They should start contributing a fair share. So I think the FCC should move forward consistent with that legislation.
Seems to me we ought to just UC that bill this afternoon. Members of Senate can get back to me on that. One other thing, Commissioner, the FCC has reviewed applications for both the COVID-19 telehealth program and the Connected Care pilot program beginning in April 2020. The applications were either granted or denied based solely on FCC staff review without public comment on their applications. Commissioner, is this a fair criticism? And has the selection process for both COVID and Connected Care pilot program been open and transparent?
Thanks for the question. It sounds like there's room for improvement on that front. We have tried to put some guardrails in place at the commission level and then move quickly at the staff level to move those through. But I take the point that we could bring some greater transparency to that to make sure that we're getting the dollars where it's needed most.
Okay, so what needs to be done? Would be the next step there?
We can work with my colleagues and see if there's more that we need to do to get common input on those applications that are pending.
Okay, well, you know, I tell you what, I think I'd like to ask you to do is check with your colleagues, and maybe you can respond on the record, a comprehensive answer there. Ms. Larson, you agree with me about maps. We don't want to duplicate where we already have service, do we? We need to make sure where the new broadband is needed. Do you agree on the importance of maps?
I absolutely agree on the importance of maps. What I want to make sure and maybe indicate here when the comprehensive maps, there are urban settings where there's not enough access. So, you know, let's be sure it's comprehensive and that we really understand where this broadband is absolutely needed for access for all.
Good. Well, you have a young man sitting right next to you there who I'm sure is is listing. Besides the existence of broadband, are there regulatory barriers in telehealth that you'd like to bring, or other barriers besides just the availability of broadband you'd like to bring to our attention?
So I'll start with broadband. You know, it is interesting when we go to different locations, you know, what the cost of broadband access is for a different remote location. And certainly the USAC funds have tried to address that. And, you know, it is, I think we've talked about this before. I know I've talked with Commissioner Carr. Application is, when you're a small critical access hospital, and, you know, the IT person is also the quality control person, maybe infection control and a few other things, the application process is difficult. And that can actually, and it's not that it's not accurate, it's not that it's not, that the information is not needed, but it's a lot of due diligence that we often try to help with. So that piece of access, again, and the funds that are available, if there's any way we can make that more readily available for those of us in need. We've come into organizations who, just a small critical access facility, who cite monthly fees of up to $15,000 for broadband access. You know, it's an incredible amount of money when you're that size of a facility. But with USAC, we typically can, you know, cut that down to much, much, much less than that. So that's an important feature.
Thank you, Ranking Member Wicker. And I think there's a lot of interest in what you've identified, not just with legislation you've introduced, but looking at modernizing how we're able to fund these initiatives, and also the editorial piece, the opinion piece that was written by you, Commissioner Carr, which I know received a lot of attention. I certainly appreciated it as well. Next, we're going to hear from the chair of the full committee.
Thank you, Mr. Chairman. Thank you for this important hearing. You and Senator Thune have done a good job of outlining these important issues. Senator Thune and I both serve on the Finance Committee, and I guarantee you these are constant issues before the Finance Committee, and we just have to figure out solutions. But thank you for your leadership, because your understanding of our infrastructure as it relates to the utility sector and these solutions is very, very much appreciated. And I want to, I think the ranking member is reminding us how important it is that we actually get the information on these maps. Now, I've seen a lot of data provided by the private sector already on this, and I think that some of the private sector data is outlining just what Ms. Larson said, that while access in some parts of the United States is challenging, affordability is a bigger problem. It is, in sheer numbers, what is preventing us from delivering something on telehealth. So we need to do both, and hopefully we can do both, and hopefully this committee can play a larger role in communicating to our colleagues what are some burgeoning technology solutions that I think could expedite us, obviously, once we see the data and information, although I think there's a lot of data and information that's already there that should point us in the right direction. On this specificity this morning, Commissioner Carr, I think you recently visited the Whitman Walker Health Center in D.C. Acting Chair Rosenworcel happened to be in the Northwest in 2019, where we visited an actual stroke victim, a gentleman from one of the basically had been on the San Juan Islands, was able to then be helicoptered, I think, over to one of the Bellingham hospitals, and then because of telestroke care, immediately they knew immediately. Actually, it might have been even before he left one of the San Juan Islands, they knew. And they said, get him down to Seattle for care. So that's the kind of system that we want, and obviously we have to have that connectivity to help in making those kinds of assessments in those rural areas. But I'm also interested in this issue of this system just in the availability of specialists. It's almost as if we could open up rural parts or hard-to-serve parts of our healthcare delivery system to the kind of care you don't have to drive to Seattle to see the specialist, or you can get some of the information or the help and support. Is that the reason I mention that is because we have so many shortages in primary care physicians, unbelievable amounts of shortages in primary care, and hopefully we can do something about that. But we also have tremendous shortages in specialty care. So, Ms. Larson, what do you think we should be doing to try to identify and help what kind of savings we would have in the healthcare system if we were able to hook up some of our most, I think of places in my state, north of Spokane, in other parts that are just hard to get to see a specialist?
It's a great question. Workforce is an issue. We have to understand, and I have been saying for a long time, that telehealth is part of the solution of workforce. We don't have enough specialists, and where they're located, they may even as a subspecialist not have enough population to even fill their profiles. So we need to think about a broader cast of network of providers who can cross state lines, who can have access to a child in rural South Dakota who has rheumatoid arthritis. There's no reason for a peds rheumatologist to be in South Dakota. There's not enough patients for him to take or her to take care of. But in a neighboring state, maybe 2 or 3 of those states in the Midwest, they could do a great amount of care if they were able to get through the licensing issues, to provide telemedicine support to the family practice provider who would collegially take care of that individual, that child, through that growth time. It's today medicine, they are trained to work collegially. Primary care providers are trained through their residency to understand the specialties and how to work with them. But if they work in a remote location, that's not available to them or the individual's family. And as you say, sometimes it could be close by, but it's still not available to them because of a distance travel. You talk about Spokane and some of those places, you're talking about airlifting, and that's just not available for everyone. But telehealth can be available. And what we find in our environment, we are often working with nurse practitioners. We're through telemedicine, we're intubating patients who are at the end of their life, guiding the hands of the nurse practitioner, placing chest tubes. These are very technical types of things. So take that and move that over to a peds rheumatologist working with a primary care in a very calm clinic setting. These clinicians know how to do this. They know how to work collegially. We need to give them the tool set, remove some of the restrictions in the licensing across the states, and let them build a broad network to help each other and support the constituents.
Well, I think this is why I say there's overlap here, particularly with the, not just with us at the federal level, like on the finance committee, but states too, because a lot of these licensure issues are at the state level. And so then how do you figure out how to get some sort of global agreement? And so I would like, for the record, if you could just tell me, you can submit it for the record, what are those, top 3 or 4 areas that you think would best be served by having, you mentioned rheumatoid arthritis, but like what are the 3 or 4 things where we're seeing a lot of activity where a licensure and telehealth delivery system could make a big dent in delivering care? And you can take that for the record, but unless you know right off the top, but I don't want to hold my colleagues up.
I will take it for the record, but I will also mention you'll for sure see behavioral health.
Pardon me?
You'll for sure see behavioral health be a part of that.
Behavioral health, yeah. Yeah, well, my colleagues, I'm sure every one of my colleagues could go a long time on sections of their state who have like no behavioral health services, like counties and counties. Thank you. Thank you, Mr. Chairman.
Thank you so much, Chair Cantwell. And Dr. Aurora, I think it'd be important to hear from you on that question from Chair Cantwell as well. So we'll make sure we submit that to the record for you as well. Next, we're going to hear from Senator Moran.
Chairman Lujan, thank you very much, and thank you to our witnesses for their participation today. Let me start, I think, with Dr. Renzone. First of all, I want to highlight a piece of legislation, as many of my colleagues have done, and also second what Senator Wicker said about MAPS, Commissioner Carr. We've introduced, several of us have introduced the Protecting Rural Health Telehealth Access Act. There's a number of pieces of legislation, and I'm involved in most of them, but this is the only one that includes a provision to allow payment parity for audio-only telehealth. And I wanted to ask you, Doctor, from a physician's perspective, why is the continuation of audio-only telehealth important, particularly as it relates to rural communities?
Thank you, Senator. I can say the AAFP did support that piece of legislation and does support it. Audio-only telehealth is incredibly important, especially for my older and geriatric patients. Part of the digital divide is just competency and confidence in using technology. And a lot of my older patients just do not feel confident in using it. A lot of them feel that if they do anything to the computer, it will break and they won't have the availability to do it, and so they don't feel confident in doing it. And we need to meet these patients where they are. A lot of them don't have computers or tablets or anything in their home, and what they have is a telephone. They feel confident with that type of technology and they know how to use it. So because they've been using it for 90 years. So when we see those folks, a way that we can get to them is through audio only or telephonic consultation. In the time of a pandemic, I spent a lot of my time trying to keep my patients into an environment that was safest for them. And frequently that was not going out in public and potentially exposing themselves to the virus. So I needed to find ways that I could get to them to help manage their chronic disease. Telemedicine was my answer for a lot of patients to be able to get to them to give them the best quality of care. And I continue to use it. I think that in the future, after the public health emergency has abated, I will still use and will still need to use audio-only services in order to reach those patients. Thank you.
Thank you for that testimony, that confirmation of the value. Commissioner Carr, you mentioned audio only. Anything you want to add to the doctor's response to my question?
I think he's exactly right, and as my testifying friend here said, we need to give doctors every tool in the toolkit, and audio is a big piece of that. I think your legislation would make a lot of progress on telehealth.
Commissioner, thank you for your recent visit to Kansas. Parsons may be the most per capita commissioner-visited community in the country, and I was not able to join you on your visit, which only means that you have to return to Kansas in the near future. Commissioner, you're aware that the FCC, USDA, and NTIA announced a memorandum of understanding to share information and coordinate the distribution of broadband deployment federal funds. Can you bring us up to date on what has transpired? Is there the necessary coordination occurring?
I'm concerned that there's not the necessary coordination for a couple reasons. One, the agreement that you reference only covers some agencies that have broadband dollars and then some of the broadband dollars that the agencies that signed it have. If you step back, you can argue that there's about $800 billion across various agencies right now that could go to broadband infrastructure, could go to other infrastructure as well. And I'm not confident that we're in a situation where we are coordinating across agencies. And unfortunately, we saw what can happen back in 2009. We had the BTOP program, which is a lot of people here probably remember, was plagued by waste, fraud, and abuse. And I'm very worried that we have hundreds of billions of dollars right now that we aren't focusing enough on implementing those existing dollars, because there's enough money now potentially to bridge the digital divide, and I don't want to see that money go to waste. So we need more focus on coordinating across agencies that have portions of these hundreds of billions of dollars.
I think that's a really important comment that you made, and I share the concern. We do spend a lot of time talking about the importance of maps so that we're putting the money where it belongs. But if the consequence, because of lack of coordination between various federal agencies and others, is so lacking, the coordination is lacking, that we're spending money that doesn't need to be spent, that's also a sin as well. And so we need to make certain that that coordination is occurring, and I would encourage you to ask Congress for any assistance that would be helpful in that regard. I would highlight for you, Commissioner, there was another memorandum of understanding for planning a rural telehealth initiative. I'd be glad to hear any update on that. I don't have enough time to take your answer. The last thing I wanted to say, is actually the second to last thing, but I only have time for one more, and that is I have some responsibilities in the world of the Department of Veterans Affairs, and they have a significant telehealth program. Any of our witnesses have any suggestions or comments that we should know as we try to improve the access of care within the Department of Veterans Affairs for those who served our nation?
Well, for my part, I'll add that the VA has been on the front edge of a lot of telehealth adoption, and that has been very good to see. Digging beneath that observation, I'd leave it to others.
We still experience latency in getting local providers eligible to provide specialty service at the VA. If they're not members of or getting, again, a credential to be on the VA staff as a provider is difficult. And so we still have that barrier.
Ms. Larson, I'm not sure, and my time has expired, but I'm not sure what you're telling me, because the VA has the opportunity to provide, in fact, has the requirement to provide community care in the community for those veterans who can better be cared for in the community. And I don't know whether you're telling me that those providers are not being allowed to provide care in the community, or you're not being able to get the necessary credentialed people at the VA.
Yes, I'm telling you, physicians have difficulty meeting the requirements to be credentialed at those facilities.
Community facilities or the VA hospital itself?
VA settings.
Thank you. Thank you, Chairman.
Thank you, Senator Moran. And Dr. Ranson and Dr. Aurora, I think Senator Moran's question is very important. If we could hear from both of you as well in regards to care for veterans in that VA setting.
Thank you, Senator. I see numerous veterans in my clinic, and I share many of my veteran patients with the nearest VA hospital. I have two, each of which are probably an hour and 20 to an hour 30-minute drive from my office. I have not heard of any program where I am able to access VA administration specialists via telemedicine. I think that's a wonderful idea. I take care of these folks and I try to keep them out of the hospital, but any time that I could teleconsult with a specialist in the VA system, it would be beneficial for our veteran patients. Thank you.
Dr. Aurora?
Thank you, Mr. Chairman. Yeah, the VA has an extraordinarily great shortage of specialists to take care of veterans. Most veterans living in rural areas don't have adequate access. We at ECHO have partnered with the VA system, and they have run more than 30 networks for a variety of diseases, including mental health disorders, hepatitis C, etc. But there is the same problem that exists in nursing homes, in the VA hospitals, that is, in our healthcare system financing, there is no real methodology to incent specialists to democratize their knowledge and enable primary care clinicians across this country and in the Veterans Administration system because to operate at the highest level of their license. All VAs that I am aware of have very long waits for specialists, and therefore these veterans have limited access. But this can be solved if we were able to measure productivity in the healthcare system differently. For example, could we account for a time a specialist at the VA spends in mentoring other primary care providers in rural areas in the VA system, in the VBOX, outpatient clinics, to provide the care locally? That is not happening because our measurement systems are all outside the VA and inside the VA focused on a fee-for-service system where a specialist only gets reimbursed for seeing the patient themselves. And that in turn exacerbates this enormous shortage of knowledge that exists in rural areas. And I think there is a potential in the VA system to change that.
Thank you, Dr. Oren. Senator Moran to respond, and then we'll go to Senator Blumenthal.
Chairman Lujan, thank you for highlighting the importance and allowing the other two witnesses to testify. I appreciate your interest in this topic. The Mission Act, which many of us were intimately involved in, allows for the Department of Veterans Affairs, and I said earlier requires, where it's in the best interest of a veteran, he or she is entitled to have care outside the VA. It's not really outside the VA, it's within the VA, but it's a community care provider, a network. And I just would highlight for particularly both of the doctors and what they just said. First of all, we expect the VA, and they tout their capabilities within the capability of providing telehealth to veterans across the country. What you're telling me is they lack the necessary professionals, particularly in specialty areas, to meet the needs. That's one area in which the Department of Veterans Affairs can reach veterans is through their own telehealth program. But the other is community care, authorized, required by the Mission Act, which says if it's in the best interest of a veteran, determined by his or her him and her, the veteran and his or her provider, then the VA must provide that care within the community. That doesn't solve the specialty care probably because there's not that many we don't have the necessary specialists in our communities. But particularly when it comes to primary care, there's an opportunity for veterans to be cared for in the community, separate from telehealth. And this is not a feature that should be forgotten and needs to be highlighted within our physician community. Thank you.
Well said, Senator Brown. Thank you so much. Senator Blumenthal.
Thanks very much, Mr. Chairman, and thank you for having this hearing during National Digital Inclusion Week. Very fitting time to have it. Broadband, in other words, high-speed, affordable broadband, is really an essential need. It's not a convenience or a luxury. I think every one of our witnesses knows the COVID-19 pandemic has only increased the digital divide, including the homework gap, but that divide can mean a life or death difference to underserved communities. On Monday, I visited East Hartford to join in the announcement of East Hartford Fiber City, a project that will bring an all-fiber internet network to every home, business, and town-owned facility that can reach speeds of 10 gigabytes per second. I want to highlight this project in particular because it brings broadband to an underserved urban area. It's not the solution for the whole state of Connecticut or the whole country because it relies primarily on private money, even though it's a public-private partnership. But we do need more projects across the state and country that provide that kind of internet access, including telehealth. So I wonder whether our witnesses can explain how underserved communities really suffer as a result of the digital divide, and in particular, low-income communities and communities of color, which face the largest barriers in accessing telehealth. I'll begin with you, Commissioner Carr.
Thank you, Senator, for the question. We've done some mapping historically at the FCC, and you're exactly right. We see poor health outcomes, lack of affordable access to internet, low income. Those things tend to cluster together. And that's why if we can get affordable internet connectivity out there, we can extend the benefits of telehealth, and it literally can save lives. That's why the Connected Care pilot we've been working on focuses on low-income Americans and veterans. To your point, COVID-19 only underscored the value of internet connection and the value of telehealth, and we can't afford to go back to the way we did telehealth before COVID-19.
Ms. Larson?
You know, I think it's really essential to say that communities do need health care, and the connectivity with telehealth, what it does is actually helps us keep dollars in that community, commerce in the community. As we can retain patients in that local clinic setting, have all of their lab work and other follow-up care retained in the small rural community versus going to the next level of care, we're keeping commerce in that community, helping it stay alive.
I want to ask a question that troubles me after a hearing that we had yesterday in this committee about data security. It was the second in a series of hearings that is focused on finding a path toward consumer privacy and protecting that privacy. I think that my colleagues and I all agree that we need to see real change to protect consumer privacy rights. And I wonder if you could tell me, and I'm going to ask Dr. Aurora, Dr. Ransone, and Ms. Larson, what specific actions do you think ought to be taken to ensure privacy? And then Commissioner Carr, we may not have time, so I may ask you to provide the answer in writing, what the FCC does to verify telehealth providers in the area of privacy. Ms. Larson, maybe you can begin.
So there are several options, as you know, for especially during the early COVID time where clinicians were allowed some opportunities to go on different aspects of providing telemedicine. As a healthcare provider, we do not allow that. So all of the connectivity we have is HIPAA compliant, and we do, of course, comply with that as a healthcare requirement.
Dr. Arora?
Mr. Chairman, Senator Blumenthal, in the ECHO project, where your state has taken a leadership role in democratizing the knowledge of the Yale University Community Health Center Incorporated and many other organizations, we have taken special precautions for data security that when a patient is presented on the ECHO project as a telementoring case study, no patient identifying data is ever shared. So the ECHO model inherently protects the data of individuals. Let me give you an example of the nursing home project that we recently launched. We had almost 500,000 deaths at one point in the pandemic, and 30 to 40% of them were in nursing homes in the United States. So we at ECHO launched 326 networks to connect, many in Connecticut, to connect these nursing homes in cohorts of 30 to these academic medical centers and other organizations. So in South Dakota, what happened was there was a nursing home where there were 40 people residing, and 30 got infected with COVID-19. 2 of them were over 100 years old. We had taught this nursing home using ECHO how to use the antibody and BAM, and essentially of the 30, 28 survived. 2 of them who were over 100 survived. This was almost unheard of in nursing homes who had COVID-19, but the right knowledge at the right place saved their lives. And no data security issue came along because no patient's name was ever discussed ever in this entire network. Thank you.
Thank you. Dr. Ransone, do you have any?
Yes, sir. I'd like to say that we take the digital privacy and security, we think that's incredibly important. The concern that we have is the affordability of HIPAA-compliant platforms. Typically, they tend to be more expensive, and trying to support the smaller rural practices is difficult just because of the cost issue. One thing I'd like to jump on that you said earlier, Senator, was regarding your all-fiber network. I only got wired internet in my home about 3 years ago, and this was after 2 years of fighting with the company in order to get it to our area. Before that, I was considered to have broadband because I had a cell phone and I had 3G coverage. Unfortunately, that type of coverage is not anywhere near good enough to allow me to access my advanced electronic health record at the office. And so there, I might have been considered to have broadband. It was not broadband that was usable and affordable for most folks. So thank you very much.
Thank you. Excellent testimony. Thanks again, Mr. Chairman, for having this hearing.
Thank you so much, Senator Blumenthal. Next, we're going to hear from Senator Plott.
Thank you, Chairman. On the topic of how we deliver, Commissioner Carr, you said in your testimony that while the benefits of telehealth are clear, barriers remain from legal and regulatory to connectivity challenges. We seem to be moving as quickly as we are able to, though it seems slower to most of us than it should be for connectivity. But on the other authorities, I'm concerned we're not moving as quickly as we need. Senator Murray and I, along with in the House Representative Latta and Dingle, introduced a bill, the TREAT Act, to try to deal with some of the regulatory challenges. You know, we have 7 states that touch our state, and our 2 biggest population centers are right on the edge of the state. Lots of people drive from other states to come to Missouri for health care, but when it's telemedicine and they're dealing with the doctor they've always dealt with, they're in a state where that doctor may have some challenges because of the the barriers to becoming licensed in that state. If anybody on the panel, starting with Commissioner Carr, have any thoughts on that problem and the importance of solving it?
Well, thank you, Senator. I think the TREAT Act is a great step in the right direction. It eliminates some of those geographic restrictions that are unnecessary in a telehealth world. Speaking of Missouri, though, I also want to say that, one of the challenges on the connectivity side is workforce, and make sure we have the telecom crews capable of building this out. And I just did a visit to Lynn, Missouri. They've got State Tech there, which is a wonderful program, training up young people to get good paying jobs, building out this infrastructure. And as a country, any infrastructure plan that doesn't include a plan for workforce shortage that we have is itself falling short. So I think that type of a program in Lynn, Missouri is a great model we need to continue to build on.
Right. Well, I agree with that. But in fact, in our state, the University of Missouri has had extension opportunities, early on very much ag focused, but later that focus expanded in every single county. And one of the things they're doing right now is trying to be sure that there's at least one location in every county that someone could go to for a telemedicine opportunity. Often your behavioral health provider is further away than your other health provider, and that's something you don't want to let get away. But if anybody has any thoughts on the challenges, last year we saw kids in college in a different situation than they had been before. Maybe these were people that had behavioral health people that they'd relied on at home, but suddenly they're 5 states away. How important is it that we figure out how to deal with that problem? Ms. Larson?
I would speak to licensing is really a barrier. As you talk about these specialists, they can provide, there's always a place that is needing them. And, if there's a lot of barrier to getting not only licensed in the state and the time that takes, some states still require them or want them to come into the state and be fingerprinted. The duplication of that for an individual, a physician who's very busy, to get all of that done across several state lines is difficult. Not to mention, typically, at least the way we provide telemedicine, we do the credentialing or appointment, if you will, with whoever the local providers are. That means that medical staff, through the conditions of participation, are required to have medical staff appointment criteria. Each of them are different. I have ED, emergency physicians, who are appointed in 200 locations across the U.S., 200 different sets of bylaws that they have to be accountable to achieve and accomplish and keep up in 200 different facilities. That's just the governance at the local site that's required by the conditions of participation.
Well, I think I'm running out of time here. I think this is something we have to deal with. I had a Zoom meeting this week with a group, the American Connection Project, 170 different members, big companies and others. The TREAT Act is the first piece of legislation they've ever endorsed, and so they endorsed it this week, and I hope we can deal with that, because if we have telemedicine, we're going to have connection to the doctors and other healthcare professionals that you want to be connected with, and that you often are connected with when you get in your car and drive. But every state has somewhere in the state that someone from another state drives to see their doctor now, and we need to figure out how they can have that telemedicine visit as well. I think you can make considerations, as the TREAT Act does, for state regulators to still have authority if things are not going the way they should, but some sort of understood reciprocity or something is really important here. Thank you, Chairman.
Thanks, Senator Blunt. Next, we're going to hear from Senator Tester.
Thank you, Chairman Lujan. I like the sound of that. Commissioner Carr, before I get into my remarks here, I just want to say I hope you heard what Dr. Ransom said, and that we give a lot of money out to folks who are supposed to put broadband in the ground, and they turn around and say, he's already got coverage when he's got crap for coverage. I mean, this is unbelievable. And so I think I'm depending on you, Commissioner, to put the boost to these guys when they don't do what they say they're supposed to do, because we're putting out billions of dollars. And telehealth is really important. I live in Montana. Weather, distance, those all make telehealth a winner. And I've heard from patients that they believe it's a winner. And quite honestly, I wasn't sold on it from a mental health standpoint in the beginning, but I've heard from veterans because I serve as chairman of the Veterans Affairs Committee over veterans, that telehealth is actually better than in-person visits in a lot of cases. So there's just a lot of positive things out there for telehealth. And we've done a lot to help push the ball forward, as the senators know, through the CARES Act and through the December Consolidated Appropriations Act that we passed in 2020. Montana healthcare providers received nearly $1.9 million. That's real money. And it came through Commissioner Carr's FCC's telehealth program to purchase telemedicine software, devices, remote monitoring equipment, and more, ultimately delivering more quality care to Montanans. Because of this funding, Montanans, they can do it at home. They can do it at their a local hospital. It may not have the kind of level of expertise there that some hospital a ways away would have. So it's a real positive thing in a state like Montana. And I know that for those folks who don't know how to use a computer, or don't want to use a computer, or don't have the up-to-date computer, there's also audio options. And quite honestly, those provide some benefits too. I'm going to start with you, Dr. Ransom. From an audio standpoint, I don't know if you do any audio telehealth, but if you do, could you talk to me about its effectiveness? Because I do know the video telehealth is very effective. And correct me if I'm wrong on that. You're the pro.
No, sir. The video is very effective, and being able to see a patient and being able to have them hold their broken finger up or whatever it might be in front of a camera is quite beneficial for me in making a diagnosis and developing a treatment plan. Audio only is quite effective, especially the most effective tool is one that we can use, right? And so if my patient can't use video, it's of no good to me in their care. So the most effective thing is what they can use. And audio only is incredibly effective, especially for my older patients. I can ask a lot of questions, and a lot of times I can decide, do I actually need to bring this patient down to see me? And an audio consultation can give me the needed data that I have in order to do that. I would like to jump in and just say that when my patient, we know that the best care of these patients is in the patient-centered medical home. And when we have our patients who travel, they go to college, they do other things like you mentioned, specifically if they're out of state, I think I can give them the best care because I've known the patient since they were an infant. Frequently when my patients go to college, I can call them. We can do telehealth visits regarding behavioral health, frequent medication refills and things like that. So we do think we need to crack that nut of interstate commerce or interstate consultation, but we support the Interstate Medical Licensure Act. We think that it's incredibly important that there's still some state control for safety reasons over the physicians, and that act, though we think it needs to be less burdensome to apply in other states and less costly to apply in other states, we think it's incredibly important to allow that patient to stay within their medical home so we can give them the best services, be it audio or video. Thank you.
No, thank you for that input. This is a very simple question, and because I only got about 40 seconds left. We put in a bunch of waivers because of the pandemic on telehealth. Number one, do you think that those waivers should be made permanent, or should we just extend them? What's your view on the waivers, and have they been effective?
I think the waivers have been effective, and I would be supportive of making them permanent. I think that we've entered a brave new world of virtual communication, and this is the best way for me to help take care of my patients in their medical home.
All right. Thank you, Mr. Chairman. I want to thank you all. It's a good hearing. Thank you very much.
Thanks, Senator Tester. Next, Senator Cruz.
Thank you, Mr. Chairman. Ms. Larson, the Biden administration has issued a number of COVID-19 vaccine mandates. One of them compels Medicare and Medicaid providers, such as hospitals and medical practices, to in turn force their employees to get vaccinated or risk losing their job. These mandates violate individual liberty. They violate the healthcare privacy of the employees. They're not authorized by law. and they could force people to receive a vaccine even if doing so is contrary to the medical advice of their own doctor. For the first 12 months of the pandemic, Republicans and Democrats together praised healthcare workers, praised doctors, nurses, physicians' assistants, technicians, pharmacists, other medical professionals for working tirelessly and despite personal risk for their own safety and health to treat Americans who contracted COVID-19. We all agreed that medical professionals were heroes. But for President Biden and for Senate Democrats, yesterday's heroes are today's government subjects who must submit. The message from Joe Biden and Senate Democrats is, do as the government says with your own health care or lose your job. Lose the ability to make a living. Lose the opportunity to provide for your family. That's the Biden administration's unlawful vaccine mandate. It is ironic that Senate Democrats are holding a hearing today about access to care, even though they're perfectly willing to let President Biden impose a policy that will cause medical professionals to lose their jobs and in turn diminish America's access to care. Ms. Larson, what are you hearing from medical professionals about their intention to submit to this mandate, and are there medical professionals who are not going to comply with this government mandate?
What I'd like to speak to is the application of telemedicine within this. So what I do hear from individuals are, because we are reaching patients across thousands of miles away, and it's the same clinicians, physicians, nurses, pharmacists, will we be requiring, the question is, what are we doing? And, we will be in compliance with what our customers in this case want. So in some cases, a receiving facility of telemedicine is saying all clinicians who are accepted on the medical staff need to be in compliance. And so it's interesting in that situation. We have to, be careful that we aren't subduing care or taking care away from them by not being compliant with the bylaws of the medical staff. And individual physicians will be taken off medical staff if they aren't compliant with the requirements. So right now, we're hearing a mix. There's, just like the nation, there's a mix of who is doing, who wants to provide care or who wants to get a COVID vaccine and who doesn't. And we're in this situation of trying to be in compliance so that we aren't taking care away from any organization.
Dr. Ransone, do you know how many doctors, how many nurses, how many healthcare providers have been fired because of the Biden administration's vaccine mandate?
No, sir. I don't have any numbers as far as termination of employment. The American Academy of Family Physicians does support the vaccination of healthcare workers for
the mandatory vaccination, regardless of whether they want to or not?
We support what's best and safest for our patients, Senator.
Does that mean the mandatory vaccination, whether they want to or not, and whether their own doctor advises it or not?
I think in a healthcare environment, each office, each hospital should be able to make their own decision about what is safest for the patients that come into their building or interact with their staffs. And I support their freedom to make a decision on what how they want their building or system to operate.
So I agree with you. They should have that freedom, and they're not being given that freedom right now because the Biden administration is forcing them upon it. I'll read to you a headline from the New York Times this week. This week, on October 4th of this week, New York's largest healthcare provider fires 1,400 unvaccinated employees. It is astonishing, after we spent a year celebrating the heroes of healthcare, that Joe Biden's solution is we are going to use government power to force you to submit, and as a consequence, fire any doctor, fire any nurse who dares make a different decision. That is an abuse of government power. It is contrary to law, and it is bad policy for America.
Senator Peters.
Well, thank you, Mr. Chairman, and thank you to each of our witnesses for a very insightful hearing. Thank you for being here today. You know, I live in a very diverse state. The state of Michigan has some densely populated areas as well as some incredibly beautiful rural areas in northern Michigan in particular and the Upper Peninsula. And what all of my folks require is access to quality healthcare that they can afford. And certainly telehealth brings state-of-the-art technology into homes regardless of where they live. It's incredibly transformative. But the University of Michigan recently put out a report that found that patients who are African American or folks who may need an interpreter or use Medicaid as a primary insurance, or certainly if they live in a low broadband area, are much less likely to access video visits. For example, it's been estimated that only 10% of African Americans and 12% of Medicaid beneficiaries were less likely to access video visits compared to audio-only visits. So we've seen these kinds of health disparities certainly play out across the pandemic. And my question for you, Dr. Ransone, is in what ways can we support telehealth services to our underserved communities that currently are not able to utilize these technologies or for various reasons may find it difficult to use these technologies?
Thanks. I think that the connectivity issue is twofold. It's access and affordability. I think that we need to work on digital literacy for a lot of our patients, especially the elderly. And I think that potentially putting out pilot programs with things such as digital health navigators to help people understand the technology would be incredibly beneficial to help them be able to interact with me as their physician. I think that we've seen that non-native English speakers and folks who have limited English proficiency don't use telemedicine platforms to access their physicians. A lot of it has to do with just the inability to understand the instructions on their iPad or their phone. And I know that when we first started with a telemedicine program to reach out to our patients at the beginning of the pandemic, I had to have extra staff time in order to help my patients learn how to connect with a digital platform. One of my front office staff would spend approximately 25 to 30 minutes with each patient just trying to get them to connect so that I could have my office visit. And that takes time away from their regular duties in the office. So I think any type of digital health navigators to help these patients access and bridge that digital divide would be incredibly beneficial for them. Thank you.
Well, I appreciate that. And a follow-up question, you mentioned also the ability to have resources to pay for these services so that it's available. You said access is about technology, but it's also affordable. We know that during the pandemic, HHS allowed certain services to be covered under Medicare, but those waivers are about to expire. Could you tell this committee why it's important to have both flexibility for billing for telehealth services, why we need to continue to be focused on that going forward?
Thank you. Well, I spend a lot of time with each visit, be it an in-person visit, be it a video visit, be it an audio visit, beforehand reviewing charts, reviewing patient history, and trying to prepare in order to see that patient to give them the most efficient and best care that I can give them. Once these waivers run out, I will be doing a lot of work for services for which I'm not going to be reimbursed. So it is pushing people more towards an in-person visit because that is the old paradigm in patient care is you see a patient in person and you treat them. When we get to more advanced ways of seeing patients, for some of the advanced models of patient care, when we, let's say we were to make global payments to physician offices, we can allot our time, we can be paid for what we do to get ready for these visits, but it takes a lot of time to prepare and then follow up from any of the 3 types of visits mentioned. Thank you.
Right. Well, thank you, Doctor. Thank you, Mr. Chairman.
Thank you so much, Senator Peters. And Senator Rosenwald, you're next. We don't have any other Republicans that are currently in the queue. Senator Warnock does have to leave now at noon, and I was just checking to see if we might be able to go to Raphael next. Senator
Mr.
Warnock?
Chairman, you do have a Republican in the queue virtually.
I appreciate that, Senator Blackburn. So, Ms. Rosen, you'd follow Ms. Blackburn, but just checking to see if that might be okay.
Okay. Are you ready for me, Mr. Chairman?
No, a Democratic member is next, Ms. Blackburn.
Okay.
I apologize. Ms. Blackburn, you are next.
Okay. Thank you, Mr. Chairman, and thank you for the hearing. As you all can see, there is a lot of interest in this hearing. I enjoyed sitting in the hearing room until I had to step out and move on to another quick little meeting. Commissioner Carr, I wanted to come to you first. Last year, the FCC did such good work setting up the telehealth program, the Connected Care pilot program that you all did. So we've talked a little bit during the course of this hearing about, funding and grants and workforce and a little bit about regulation, things that would inhibit moving forward with this program, growing it. And of course, we've talked about using it for veterans. And Dr. Ransone, thank you for your comments that are there. Ms. Larson, you've talked some about serving the underserved. So let me know if there are any legislative or legal hurdles that we need to move out of the way so that we can continue to grow this program. What do you see?
Well, thank you, Senator, for your leadership on telehealth. First, I'd say the Connected Care program is funded out of the FCC's Universal Service Fund, and as a statutory matter, there are some threats to the stability of that fund, and that's why I've put forward the idea of looking for legislation that would help us expand the base of contributors into that to include big tech. I think the other statutory issue that comes to mind is the HHS waivers. I know you personally were involved in helping to secure those waivers last year that paid dividends for really so many Americans. So I think statutorily addressing those waivers in some type of longer-term basis is a key step going forward.
Okay, thank you for that. And Ms. Larson, as we were discussing the waivers with Senator Tester, I could see you wanted to weigh in on that. And as Commissioner Carr just said, this is one of the first things I did when we had the pandemic at its beginning. In the earliest stages, I asked President Trump to give that temporary relief and those waivers for telehealth provisions. We had this legislation for about 3 years, and people didn't seem to think it was a necessity, but of course, COVID has proven that it is a necessity for individuals with complex medical conditions and who are not in proximity to a healthcare provider. So I want to give you an opportunity to weigh in on why these waivers need to be made permanent.
Well, thank you for your leadership on all of those waivers. It has been essential for us to be able to provide the telehealth services in many locations. And I'll just emphasize, if HHS were able to untie their hands a bit to determine appropriate telehealth practices and services and providers, it would be tremendous. Many of the rules and regulations are written prior to this type of technology, and so if we could look at that in a more global way and untie their hands, allowing them to do what's appropriate today. And then I'll also, empower the safety net providers, the federally qualified health centers, as well as the rural health clinics, making sure that we can have telehealth services continue in those locations and those remote geographies.
Okay. Yes, we have the legislation that would allow the across-state line utilization of telehealth. Tennessee is a state that borders 8 states, and we have areas where those physicians are located inside Tennessee, and then other areas against the state line where it is across that state line. So we do think that that is vitally important. Dr. Aurora, one quick question for you. On the ECHO program, Vanderbilt has done a really admirable job and its own ECHO program, which really does help in training those providers on caring for adults on the spectrum, as well as providers to treat patients with opioid abuse disorders, pediatric behavioral health. So talk for just a moment about flexibility. Why flexibility is important to the success of this program and the role that you see for public-private partnerships as we look to grow this program.
Yeah, Mr. Chairman and Senator Blackburn, thank you for your question. In addition to Vanderbilt and all their amazing ECHO programs, Tennessee State University also runs an ECHO program for children's care. And these programs have an extraordinarily powerful impact on bringing care for, let's say, children with autism and all over Tennessee. But there is a challenge for Vanderbilt and East State University. All our current ECHO programs are funded through one-time grants or support from the executive branch through a short amount of one-year funding, or philanthropic support is a very major way ECHOs. We currently have close to 800 such networks operating in the United States. And in the United States alone, in 2020 alone, more than 500,000 healthcare providers participated. Yet the entire network is operating on philanthropy or federal grants, etc. We need policy change so that each of these academic health centers, large not-for-profits, are actually incented and funded to democratize their knowledge. So every one of the members of Dr. Ranson's community of family physicians has the ability to be mentored to provide best practice care in their local community. And that requires significant policy change. And Senator Blackburn, I would greatly enjoy the opportunity to work with you to bring this policy change so such universities can be supported.
Well, my time's expired. We will follow up with you. And Mr. Chairman, thank you.
Thank you, Senator Blackburn. And I also want to thank Senators Rosen and Hickenlooper for their indulgence. Senator Warnock, you're next.
Thank you so very much, Chairman Lujan, and it's great to serve alongside you on your subcommittee. COVID-19 has put a strain on all of us, and it has been particularly challenging to our healthcare systems. But one consequence of that is that it has forced advances in telemedicine that otherwise would have taken decades. In response to the pandemic, for example, CMS allowed telehealth flexibilities and encouraged Medicaid programs to follow suit. So this is some innovation that is a consequence of the challenge. This has allowed patients to remain in the safety of their homes while receiving care. It has allowed providers to safely provide high-quality care and to be reimbursed for it. However, due to the politics of healthcare coverage in our country, Medicaid non-expansion states like Georgia have left some 4.4 million Americans in the coverage gap. In the case of Georgia, 500,000 Georgians who cannot access these services. This means that Georgians are forced to delay life-saving treatment in the midst of a pandemic. Dr. Ransom, can you tell me what it would mean to patients and providers and hospitals? By the way, we've had 10 hospitals in Georgia to close in 10 years because of our refusal to expand Medicaid. What would it mean for these communities and the other 11 non-expansion states were we to expand Medicaid?
Well, thank you for the question, Senator. I'm from Virginia, and we were a state that delayed expansion of Medicaid. And when we eventually did expand it, it allowed us to see over 400,000 new patients in our healthcare systems across the Commonwealth. By allowing these folks to receive coverage, we've been able to save lives. We've been able to initiate care sooner, and we've been able to prevent disease. So Medicaid expansion has been essential for us to deliver equal and equitable care across the citizens of our Commonwealth. Thanks.
Can you speak specifically to the impact of this for rural communities in your state? When I moved around Georgia, especially with the refusal to expand Medicaid, it seems to me that it's the rural communities that have been most hard hit by the politics of healthcare. Can you talk about the impact, particularly on rural communities?
Yes, sir. Living in a rural community, I've got many patients who were uncovered prior to the expansion of Medicaid. One patient in particular, his name was Sam, delayed coming to see me after he lost his job. He did not have Medicaid because his wife worked. And he delayed coming in to see me by approximately 9 to 10 months. By the time he came in, he was quite jaundiced or yellow in color. And we got him in. We got the services done under some provisions of care for folks who were uninsured. But unfortunately, he ended up passing away from a cholangiocarcinoma, which is a cancer of the gallbladder and gallbladder duct. I think if we had been able to get him in sooner when he first had symptoms, we would have been able to save his life or at least ease a tremendous amount of suffering that he had near the end of his life. Medicaid expansion in our area has been incredibly important to get folks into our office. My wife, as I said, is a pediatrician. About 50% of her patients have Medicaid. I've probably doubled the number of Medicaid patients that I've been able to see in my office since we've had expansion. And it's enabled me to give them better care because they will actually come in when they first start seeing symptoms. Thank you.
Thank you. So you see firsthand, as given your position as president of the American Academy of Family Physicians, the ways in which this is an equity issue around healthcare generally. We've got Medicaid in 38 states. Imagine having Medicare in 38 states or Social Security in just 38 states. But this issue around the digital divide is also an equity issue. About 1 in every 11 locations in Georgia lacks reliable broadband services, and 75% of these unserved locations are in rural areas. Commissioner Carr, we are working right now, and I was proud to join Chairman Lujan and others to champion increased broadband funding in the bipartisan infrastructure package. I hope the House will pass it soon. But even if that bill were signed into law today, it could take many years before some of these areas are served with high-speed internet. Commissioner Carr, what are some short-term solutions that Congress and the FCC can pursue to expand telehealth access in areas that currently lack broadband?
Well, one thing we can do very quickly is we have about $326 million that's slated to come to Georgia as part of our RDOF initiative over 10 years. That could bring service to about 179,000. So we need to accelerate the process of getting that money that Georgia broadband builders won at the end of last year actually out the door. So I think implementing the existing funds, because there are billions and billions out there that we can put into the ground, I think that's important while the discussions go on about additional broadband funding.
Thank you so much. Thank you, Chairman.
Thank you, Senator Warnock. And again, Senator Rosen, thank you so very much. You are next.
Thank you, Senator Rosen.
Oh, of course, of course. Thank you both, Chairman. Thank all the gentlemen for being here and women for being here, everyone, all the witnesses for being here today. It's a really important topic. Senator Peters, Senator Warnock, others have talked about rural areas. I just want to add that in Nevada, 280,000 citizens of Nevada, my constituents, that live in rural areas, nearly 10% of our population. So it's really, really important to us. But I want to actually talk a little bit about provider shortages, because earlier this year, Senator Murkowski and I introduced the bipartisan Improving Access to Healthcare in Rural and Underserved Areas Act. It's going to bring specialists in person or through telemedicine, like we're discussing today, to health centers and rural clinics. So, Dr. Ransone, Can you talk to me about how we can use telemedicine to leverage the providers that we have now? Because we're facing severe provider shortages, and what can we do actually in conjunction with that? Maybe having our EMTs, our mobile clinics, home visits by nurses. With the shortage of providers everywhere we go, and we know we need to increase them, but how can we potentiate with other things what we do in rural or remote underserved areas?
Well, Senator, I'm a big believer in team-based care, and I'm a believer that the physician-led team-based care consisting of nurse practitioners, physician assistants, potentially EMTs and so forth, can greatly expand our access to patients in need. I have had telemedicine visits where I had a home health nurse in the home of one of my patients where I could connect via a virtual video visit where the RN in that patient's home acted as my eyes and ears and looking at the patient. The reason we had to do that is because the patient was about an hour away and wasn't able to be transported. We don't in our rural environment, we have no public transportation. And they had no way to get to me, but I could get services to them. And that allowed me to take what I consider to be great care of that patient. And again, it was within our medical home. We could have people acting as our eyes and ears to help take care of that patient. One thing that when you were speaking, it made me think, wouldn't it be a great thing? We know that physicians tend to settle within a certain radius of where they're trained. Wouldn't it be a great thing to be able to get young physicians, potentially resident physicians, out into rural and underserved areas where they're able to communicate with their attending physician via telemedicine so that they know an area, we can get them there before they've completed their training and potentially keep them in those underserved areas after they graduate. Thank you.
Yeah, I couldn't agree more, and I agree with you on the team approach. We talk about connectivity or technological issues. Maybe people don't have an iPad or they don't have the right technology to connect. This is where someone coming to their home can really help them get the services that they need. And speaking of other services, we're talking about, so many of my colleagues, the access for mental health for our K to 12 students. They really suffered so much during the pandemic with teleeducation, trying to learn, missing their friends, all of that nationwide. We just know that there, in rural areas in particular, there's no licensed psychologist, or there's such a shortage. 94% of counties actually have no licensed psychologists. So telemedicine, again, can help fill this provider gap. And so what other things do you think, Dr. Aurora, that what we can do about pediatric mental health care, access, again, using this approach to get into people's homes somehow with maybe a provider on the other end of the line?
Yeah, Mr. Chairman, Senator Rosen, thank you for your question. Your state of Nevada, University of Nevada, Reno has done a tremendous amount of work with the ECHO model to bring access to care to rural and underserved areas. They work in the area of opioid use disorder, medication-assisted treatment, mental health, antimicrobial stewardship, and even in sports medicine. And I think that problem you've highlighted is one of the biggest problems of the healthcare system, the shortage. One potential way to ameliorate the problem, not completely solve it, is the idea of what we call task shifting. Dr. Ranson mentioned this briefly, but there are physician assistants, nurse practitioners, nurses. If they are mentored in a telementoring model in which all teach, all learn, we have demonstrated in hundreds of publications now that we can upskill them so that they can provide the care where patients live. Now, this upskilling occurs in a method which we call all teach, all learn, where these physician assistants and nurse practitioners learn from each other. They learn from experts at the university, and together discuss cases, ultimately with the idea that they become experts in this situation. I'd give you an example out of this country, in India, where the leading academic center in Punjab in India was treating 1,500 hepatitis C patients. And they adopted the ECHO model in every district hospital and now have treated more than 90,000 patients with a cure rate of 93% just by upskilling and task shifting of the kind that you can do. Effective task shifting requires three things: a multidisciplinary team of experts, case-based learning, and mentor-mentee relationships. And with current expansion of broadband capacity that we are talking about here, we can achieve those objectives in this country. Thank you, Senator.
Thank you. I really appreciate all the thoughtful answers today and look forward to working with you on positive solutions. Thank you.
Thank you, Senator Rosen. Senator Klobuchar.
Well, very good. Thank you so much, Senator Lujan, for your leadership on this, as well as other issues related to getting information out to your constituents, the people in this country, and certainly telehealth. Our states may be a little different for temperature, Chairman, but we both have significant rural areas and know how important it is to get health care in innovative ways. And I also want to thank Senator Thune. He and I actually led a bill on telehealth before it was cool, like years ago when no one was talking. And part of that was we have major healthcare systems based in our states, and one in South Dakota, obviously Mayo in Sanford, Mayo in Minnesota, and they have wanted to reach rural areas and trying to figure out how best they do that. So I think I'll start out with you, Commissioner Carr. You testified, highlighted in your testimony some of the challenges that rural communities face. What kind of investments, and you all know we just did in the bipartisan infrastructure bill that we're very proud of, that passed the Senate, $65 billion when it came to broadband. And that is getting to these very areas that may not have an expert in a certain medical field next door. So it goes hand in hand. But do you want to talk about how important it is to get the broadband to make all of the telehealth work?
Yeah, thank you, Senator, for the question. You know, we do need billions and billions of dollars to finish the job of bridging the digital divide. And I think the most important challenge at the moment is implementation, because we have a lot of dollars, for instance, already spread out across Department of Ag, Commerce, Education, Treasury. We got to make sure we move in a coordinated way so we're not putting money on top of other dollars or wasting it, because this issue is just too important to quickly bridge the divide to not fully coordinate on this. So I think that's going to be the biggest challenge, is less so than the dollar amount right now, given the desire to invest in it, but is the implementation of those dollars.
Good point. And I think part of this is mapping, as you know, and Senator Wicker, and we've talked about that. And we've actually had a Minnesota witness where we were commended for some of our mapping. But it's also about the accountability. You know, this issue where it goes out to a big telephone company, they don't actually build out. And one of the things I like about the bipartisan infrastructure bill is a lot of that's going to be focused out of Commerce with Secretary Raimondo. I had her in we had a long discussion about the clawbacks, and like if they're not actually doing it, that the money can be clawed back. And I think that accountability piece of it's going to be really important. And as you point out, Commissioner, there's also other funds and other things, but just getting it out there. Ms. Larson, the Universal Service Fund Rural Healthcare Program funds modern telecom broadband services. In your view, how can the FCC work with government partners and the private sector to coordinate the integration of telehealth?
The USAC funds, as we've mentioned earlier, are very important to our rural geographies. And you're right, the local telcos often don't have the circuitry built out. So how do we make sure that that circuitry is built and available to our rural communities? And ease of a collaborative application for USAC funding would be really well embraced by our rural communities.
Very good. Another question of you, and then maybe Dr. Aurora. The pandemic has shown about how we need to connect with family and friends. You know, we lost my dad this year, but during the pandemic, he was in assisted living, and that was one of the only ways, of course, I could talk to him was through the internet. And we had some very interesting things with iPhones that they're trying to hold up with him. He had Alzheimer's, so you can imagine suddenly this voice is coming on the thing. And it did make me think about how having some of these facilities, getting them or making sure they have the screens and the way you can do this for people to be seeing their loved ones in a bigger way. And that's why Senator Capito and I introduced the Access Act to expand telehealth support for seniors for virtual visits. Of course, it was pandemic based, but really the same thing applies for out of town relatives and all kinds of things you'd like to use it for. Ms. Larson, in your view, how will sustained telehealth, coupled with in-person care, bolster health services for elderly communities?
You know, it's very important to understand that our telehealth can be the end of the clinical service requirement, and intervention can be ordered and implemented via the phone or video, and/or it can be noted. You can note that this individual needs to come in to a clinic visit face-to-face, maybe for an advanced tele or non-telehealth, an advanced in-person visit. What's really important about that is that you need both to really get early access to the individual, and our seniors, again, with mobility issues and just not, you know, we've understood that being home and sequestered a bit, not being exposed to viruses or other situations, and they really are more comfortable in their home. Can we retain the telehealth visit in the home where they're comfortable, they're accessible, and then only bring them out of their comfortable environments into clinic environments as needed?
Very good. Dr. Rohr, you want to quick add anything?
Sure. Mr. Chairman, Senator Klobuchar, your state has been a leader in the telementoring echo platform out of the University of Mississippi.
I knew there was a reason I ended with you, Dr. Rohr. Now continue on. Yes.
Thank you. Mayo Clinic, Hennepin Healthcare, Catholic Health Initiative, St. Gabriel's, they've used echo for opioid addiction, viral hepatitis, and the nursing home echo project was amazing in that Hennepin Health System mentored nursing homes in the entire state of Minnesota so that patients could get the best possible care there. But the challenge, again, Senator Klobuchar, is the same. All these institutions are working either on philanthropy or, in this case, the nursing home project, a federal contract that we got from AHRQ, which we passed on to Minnesota. But there's no long-term sustainable way to support these institutions to democratize their expertise so that every citizen of Minnesota can get the care they need, because every provider, nurse, doctor, community health worker is mentored with the best care, best knowledge. Thank you.
Yes, thank you. And I would note we have one of the lower death rates for seniors from COVID. And I think a lot of this was a coordination. And Dr. Ransom, I'll put a question on the record. Thank you for your good work. Thank you.
Thank you so much, Senator Klobuchar. Commissioner Carr, I wanted to follow up on a line of questioning from Senator Wicker. Is the Connected Care pilot program established by law or regulation?
Connected Care looks to our general Universal Service Authority, and then we stood up a rulemaking procedure to stand it up, and then applications come in, and so at that point it's a blend of adjudication rulemaking, but it's a regulatory program we stood up pursuant to the Telecom Act.
And did the FCC under Chairman Pai increase the Universal Service Fund contribution factor to collect the additional $100 million to support the Connected Care pilot program?
The $100 million comes out of the general Universal Service Fund, yes.
And do you believe that the rural health care program established by law has adequate funding?
Yes and no. No, we have hit the cap in years before. We added some additional funding to it. We also allowed the rollover of funds to address it. But without getting into the weeds of it, the answer is we need to devote more resources to this to make sure we have the sufficient, predictable level of support needed. And if that's more money, then it's more money because that's what the statute requires.
And while you've spoken out publicly with the next question and responded to Senator Wicker here as well, I still think it's important to hear from you on this in the hearing. How should the contribution factor be reformed to ensure that all programs under the Universal Service Fund have adequate resources?
I think there's a couple ways to do it. What we do now is we assess a 30% charge roughly on the telephone portion of consumers' bills, not the internet portion. Some people have said we should just shift that charge over to the internet bill, which would effectively increase the price of internet at a point in time when we are all very focused on the affordability challenges. The idea that I've thrown out that is also reflected in that legislation is we should look to some set of large technology companies to begin to contribute into that fund to help stabilize it. One way you could do it in a sort of a targeted way is looking at digital advertising services revenues, which is an over $100 billion a year in revenue. So you could eliminate the 30% charge from customers' bill and replace it with a single-digit % charge on the digital advertising revenues. And it's a much more difficult charge when placed there for it to actually find its way back into hitting a consumer directly.
I just wanted to thank you for raising this. I want to recognize Chair or Ranking Member Wicker for the work he's done in this space. And it's something I certainly agree with. I think what we've heard today are many ideas that have strong bipartisan support. The affordability piece here is one that's going to be critically important. Chair Cantwell reminded us 90 million people across America today don't have a connection because they can't afford it. It's why the emergency broadband benefit mattered. It's why the inclusion of affordability in the bipartisan infrastructure bill matters. But we've got to fix this other one. Yep. And I don't believe people should be paying that surcharge for long distance calls. I don't think people should be paying for long distance calls. I often am at my mother's home, and I've shared this with several, and mom's going to call a family member that lives out of state, and she picks up her landline. Say, "No, Mom, use your mobile." And she goes, "Oh, yeah, you know, right. It turns out it doesn't cost you anything extra if you use your mobile device if you have a connection." It's an old revenue stream. Yeah. And when we can modernize in a bipartisan way to make affordability real and support these other programs in a way that does not directly hit the consumer, but goes after the advertising funding that it turns out those companies benefit from when more people are connected. Yep. It's in their interest. So I'm hopeful that we can find a strong bipartisan approach in that particular area. There's some other questions that I have today, but I'll submit them into the record. Oh, very good. Well, before we close the hearing, I wanted to recognize one of our colleagues who joined as well, and I'll turn this over to Senator Young.
Well, thank you so much. I appreciate that, and I thank our
Senator Young, we may have a bad connection there. We're going to check with your office. 1 second, sir.
Okay. Okay. Thank you.
I see that the
it appears that we have a better
to do.
It appears we have a better connection. Senator Young, you're recognized. It appears that we do have a bad connection with Senator Young right now. I don't know that we'll be able to get him back on. I'll ask one follow-up here as we go, and we'll see if we get Senator Young back. If not, we'll close out the hearing. The other questions that I had were along the lines of, because of the conversation we've had today and the data that we know from care that constituents, patients are receiving across America benefiting from telemedicine now, whether it's a patient to their provider or it's provider to provider telemetry services, there's data caps out there as well. And there needs to be a real conversation about data caps as well. I think it's an old technology, it's an old revenue stream. But nonetheless, especially when it comes to telehealth, people should not be timed out when they're accessing care, especially what we've learned from veterans. The VA took this on, and there were some benefits that we saw because of it. So rather than asking those questions in this hearing, I want to have a follow-up conversation about this and see if there's a way that we can get some bipartisan support in looking at this as we're modernizing, especially with the investment across America. One last check for any of our other colleagues. We're trying? Oh, very good. Senator Young, you're recognized, sir.
All right. Thank you, Chairman. I really appreciate it. And it's good to be with our panelists. And I'd like to ask a question of Commissioner Carr. Incidentally, it's good to see you again, Commissioner.
Good to see you.
So my question, I'll lead into it by laying the groundwork about Indiana and our maternal mortality rates. Unfortunately, our state has one of the worst maternal mortality rates in the country, although it has improved somewhat in recent years. Hoosiers aren't alone in facing maternal health issues. According to the CDC, severe maternal morbidity impacted more than 50,000 women in the United States in 2014. And the rate of severe maternal morbidity increased nearly 200% from 1993 to 2014. Now, this is a trend you would expect to hear about in a third world country, and it's one that we have to reverse here in the US. So earlier this year, I've worked with some of my colleagues on both sides of the aisle, Senators Rosen and Fisher and Schatz and myself, introduced the Data Mapping to Save Moms Lives Act. This was swiftly reported out of the Commerce Committee. Our legislation would utilize data mapping to show where high rates of poor maternal health outcomes overlap with lack of access to broadband services. And the objective here is to help identify where improved access to telehealth services can be most effective. The 2020 annual report from the Indiana Maternal Mortality Review Committee specifically identifies increased access to pre- and postpartum medical and social work telehealth services as a recommendation to prevent maternal mortality. So, Commissioner Carr, with that lead-in, what steps do you believe we must take to increase access to telehealth services to address maternal health and other important healthcare issues?
Well, thank you, Senator, for your leadership on this. I think your legislation would go a long way towards that, and I think as contemplated by the bill, we could include that in these maps that the FCC is working on right now. And to your point, that would help us to direct resources in the right direction to make sure we provide connectivity. I visited a healthcare clinic in Virginia that addressed some of these issues and would send expectant mothers home with connected blood pressure monitors and other devices, and they saw significant benefits. So if we get connectivity and allow these telehealth services to be funded to provide it to these moms-to-be, we can literally save lives as your legislation lays out.
Well, that's what myself and some of my colleagues who've helped champion this effort believe, and I'm encouraged to hear you say that. Commissioner, how close, and you may have covered this earlier, but how close is the FCC to producing these new, more granular maps as directed by the Broadband Data Act?
I don't know, Senator, and I think that's a problem. As I indicated earlier, it's a bit of a black box. We got the funding from Congress, I believe, at the end of last year. In March of this year, I said the FCC should set the goal of finishing those maps, at least targeted versions, this fall. I don't expect it's going to happen this year. Obviously, there's a lot of people at the FCC that are working very hard on this, but we have to get those maps done. If it means paring back what's included in the first version, then we should do that. But we have to get targeted maps out. It's the key to unlocking that additional funding from RDOF 2. It's key to getting the 5G fund going. And it's key to making sure as we have these billions of dollars across agencies that funding can go through these completed maps so that we don't have overbuilding. But unless those maps are done, we're either going to have to hold back some of those billions of dollars that other agencies have, or it's going to go out there in an uncoordinated manner.
Well, I hope you'll let myself and other members of the committee know if there's anything we can do to expedite the process. Commissioner Carr, once again, last time we dialogued within the committee, the FCC had just recently stood up your $100 million Connected Care pilot telehealth program. Can you provide us just a brief update on the program and lessons learned or notable takeaways thus far?
I think the most surprising thing has been the uptake in telehealth generally, particularly with COVID-19. It has been less of a user issue, less of a technical issue, and I think what we've been holding things back were regulatory and legal barriers and to some extent funding. And so I think these programs are making a big difference. So far, Indiana has received about $6.7 million in telehealth funding, not from the Connected Care pilot yet, but from the emergency COVID-19 programs. And so I'm very excited to see the data come in that I'm confident is going to show improved health outcomes.
I believe that'll be the case as well. So thank you so much, all, and back to you, Chairman.
Senator Young, thank you so very much for being a part of this important hearing today. Dr. Ransone, Ms. Larson, Commissioner Carr, and Dr. Aurora, thank you for being here today, and your testimony helped illustrate how the digital divide is standing in the way of connecting all Americans to essential telemedicine, remote health monitoring, and telementoring. Now, we have a lot of work to do. Rural, Native American, Hispanic communities, whether you're living in big cities or in the most rural parts of our country, so many people are effectively cut off from many of the benefits of telehealth. And we all understand the urgency and the importance of connecting every American to high quality, affordable, resilient, fast broadband. Without it, the current patterns of inequality will continue to grow, and we urgently need to deliver this relief to communities across the country. Families must be able to talk to their doctors without worrying about hitting a data cap or getting cut off. So there are many other challenges we have to solve. In the end, critical remote monitoring systems must remain online during network outages, bad weather, and natural disasters. And under the leadership of Acting Chairwoman Rosenworcel, the Federal Communication Commission has been able to make progress here, even with a 2-2 commission. Now, imagine the progress that the FCC could make if there were 5 members. It's simply unacceptable and inexcusable that there's no urgency from this administration to nominate a 5th commissioner. And I would say nominate Acting Chairwoman Rosenworcel, not just for another term, but to be the full chair of the commission. I don't understand why this has not happened. I just want to close with this. I want to urge President Biden to renominate Acting Chairwoman Rosenworcel, to nominate a 5th FCC commissioner, and a permanent head of NTIA. We heard from many senators today about the importance and the urgency to get these dollars into communities, expand capacity with telemedicine, the funding that was made available through spectrum auctions to get this back into communities, $1 billion that was appropriated to NTIA in the previous Congress for Native American connectivity, CARES Act, American Rescue Fund, the bipartisan infrastructure. If we're going to get this right, we need all of these positions filled, and we're running out of time. If there's not urgency in appointing a 5th FCC commissioner, renominating Commissioner Rosenworcel, there's going to be 3 FCC commissioners instead of 5 in January. It's unacceptable. We all have to work to expand these programs, but we need these positions filled. These are priorities I've long advocated for, and I'm going to continue to raise my voice in that fight. Now, the hearing record will remain open for 2 weeks until Thursday, October 21st, 2021. Any senators that would like to submit questions for the record for the witnesses should do so by that date. We ask that your responses be returned to the committee by November 4th of 2021. That concludes today's hearing.